You are welcome to a new lecture series for psychiatric emergencies, and you are residents of emergency medicine. So we are here with the introduction of psychiatric emergencies. The overview of this session will be definitions and typical scenarios of acute behavioral emergencies, legal and ethical considerations in emergency medical response, importance of early recognition and intervention, practical strategies and safety, in terms of initial assessment techniques of behavioral emergencies, use of restraint, sedative, and legal considerations in psychiatric emergency, team communication strategies, and personal safety measures. So, the psychiatric emergencies principles are recognition of behaviors that pose risk to the health provider, patient, or to the others, or to the environment, assessment and management of basic principles of mental health system, suicidal risk. The mind and body are inseparable in terms of illness affects a person's behavior, and physical illness can alter the patient's behavior, or the change in mental state can affect the physical health as well. So the two things are interrelated and to be looked upon in emergency unit. Condition that may pose a risk may be acute psychosis, agitated delirium, cognitive disorders, thought disorders, mood disorders, anxiety disorders, substance related disorders like substance intoxication and substance withdrawal, patterns of violence, abuse and neglect against child and adolescents and women and elderly. The definitions are the definition of behavior is the way the people act or perform. The behavior may be overt or covert. The overt behavior is obvious and generally understood by those around the person by watching the gesture and action of the patient. Covert behavior is a hidden meaning and intentions which may be in the mind of the patient and may be intended to do harm to self, others, and the environment. By definition, psychiatric emergency is behavior that threatens a person's health or safety and the health and safety of the another person. So the person's safety and other safety is important to be dealt with. And in another terms, a disturbance in thought, mood and or action which causes sudden distress to the individual or others and sudden disability or death, thus requiring immediate management is also psychiatric emergency. The cause of abnormal behavior may be biologic or organic, like organic brain syndromes, conditions that alter the functioning of brain, like delirious state. Environmental factors like psychosocial and sociocultural influences may also uh, cause the behavior to be harmful to others or to the self. Consistent exposure to the stressful event may also result into the harmful behavior of the person. Sociological factors affect the biology, behavior, and responses of the person. So all the environmental and psychosocial and cultural aspect can also influence the behavior in a dangerous manner. Injury and illness results in distress and impair coping mechanisms. The long-term illnesses like complicated diabetes, complicated hypertension, or other condition may also lead to uh, behavioral changes. Acute trauma, uh, for example, acute stress reaction in lieu of some stressful situation which is acutely happened in the life of the person, which may result into the behavioral changes, which is acute, and post-traumatic stress disorder, which is the late consequences of a traumatic situation. Substance related disorders like related to alcohol, illicit drugs, and other substances may also be cause of the abnormal behavior. Now coming to the legal and ethical considerations in emergency medical services response, the act which we have is Mental Health Care Act 17, and it has various chapters talking about various aspects of caring of mentally ill people. And this is the brief and glimpse of the Health Care Act. The chapter 3 is regarding the Advance Directive, 4 for nominative representative, 5th for the right of the persons with mental illness, and 10th for the mental health establishment. In the detail, we will get to know about the mental health care in the detailed lecture. And this is the chapter 12, which is regarding the admission, treatment and discharge, and it particularly talks about the emergency treatment and the prohibited procedures, including restraints and seclusion. We will learn about this aspect in another detailed lecture. Now coming to the general principle of the psychiatric emergency management is to ensure the scene safety. The first thing is save yourself when in doubt, and do not act alone when there is high index of suspicion of violence or hostility. Relax the environment by removing stimuli, and search for a medical cause first behind the behavior, because many of the physical condition may lead to the behavioral disturbances. If the person found to be ill due to psychiatric illness, attempt verbal de-escalation and use the calm and firm voice to control the environment. Inform the patient aggressive behavior is not acceptable in a polite manner. Offer oral medications to help the patient return to the calm state, like benzodiazepine. Obtain consent when possible. Be clear in your explanations. Do not use the sentences or words which have abstract meaning or hidden meaning. The instructions should be clear and should be understandable by the patient. Situation with a strong behavioral component may have a sudden and unexpected turns of the event, so keep in the mind of the covert behavior of the patient. Patient assessment. The assessment of patient with a behavioral emergency differs from the other method in which the healthcare professional is the diagnostic instrument. After ruling out the organic causes or physical causes, the mental state examination and your observation will be the key diagnostic tool to diagnose the condition. The assessment is the part of the treatment also. While you are doing assessment, you are also calming down the patient or pacifying the patient as well. Mental status examination is important in assessment, and use coast map. We will discuss coast map after in the slides. Examine the skin temperature and moisture to rule out any organicity due to autonomic hyper activity. Inspect the head and pupils for other organic reasons. Note unusual odors on the breath for substance intoxication. Examine the extremities and check for needle tracks, tremors, urinator weakness, or loss of sensation to rule out the substance use, the intravenous substance use, and tremors for withdrawal and other neurological conditions, and urinator weakness and loss of sensation for the obvious CNS involvement. During the assessment, clearly identify yourself, your name, your designation, and for what you are there. And identification is also helps in giving authority, somewhat authority in front of the patient, and patient may found respectful towards the identity and maybe calm down. And for a general impression, assess appearance, posture, and people of the patient. Limit the number of people around the patient, so crowd should not be there, but sufficient number of staff should be there to protect in case of violent and hostile behavior and harm to self. Stay alert to potential danger and keep in mind the covert behavior of the patient. Airway, breathing, and circulation. Being a resident of emergency medicine, you already know what to do to establish airway, breathing, and circulation. So this is the coast map, mnemonic for the mental state examination. C is for consciousness. Check the level of consciousness and concentration of the patient. Orientation to time, place, and person to rule out the delirious-like condition. Activity, check for the activity, behavior, movement of the patient, the rate, volume, flow, articulation, and intonation of the speech. If this is if there is any irrelevant or incoherent speech, or maybe there are flight of ideas. Check for the thought. Is the patient making sense? Whether the patient is conscious or seems to be unconscious because of the sense of the thought. Memory, check for the recent, remote, and immediate memory. Affect and mood, do the inner feelings seem to be appropriate? Affect should be appropriate as per the psyche of the patient and the environment of the patient, whether they are matching or not. And perception, whether hallucinations or other perceptual abnormalities are present or not. And particularly in the case of command hallucinations, patient may become hostile due to the hallucination giving command to the patient to harm to others or may harm to the environment. So be cautious regarding the perception of the patient. Communication techniques begin with the open-ended questions so you can get the clear answer uh, what you want to know, and do not use the question which has yes or no or leading questions. Let the patient talk enough so one can have idea what is going in the mind of the patient. Listen and show that you are listening and you are an active listener so the person can come out easily with their feelings. And use of how and what questions should be more to communicate and to find out the psychopathology. Adjust approach the as and when needed during the communication techniques. Do not be afraid of the silences. Silences are the part of the mental state examination, and every moment shouldn't be filled with the words, and silence is also a kind of finding. Acknowledge the level feelings and do not argue with the patient. The argument may escalate the agitated feeling in the patient, and patient may become more violent or hostile. Crisis intervention skills. In crisis intervention skills, be calm and direct towards the person. Exclude disruptive people and sit down preferably at the 45-degree angle. Stay with the patient at all times. Bring all the medications. Never assume that it is impossible to talk with any patient until you have tried. In case of crisis intervention, maintain a non-judgmental attitude. Do not impose your own belief, ideas, and thought onto the patient. Provide honest reassurance. Develop a plan of action. Once the plan is set, allow the patient to exercise some control. So, so in the last, what is next in the row? Next in the row in the series of lecture, you will have lectures on violent and homicidal patients in emergency resulting from substance intoxication in detail, substance withdrawal in detail, psychiatric aspect of domestic violence, elderly and child abuse and rape, suicide and para-suicidal behavior, delirium and organic mental disorder, depressive stupor and catatonia, fatal side effects of psychotropics and management, lithium toxicity. Lithium is used for mood stabilizer in case of bipolar disorder, so it can lead to toxicity. We will talk about that. Approach to the panic attacks in the emergency, and Mental Health Care Act 2017 and related to emergency conditions. So thank for the patient listening, and wait for the details lectures to be taken by the various faculties. Thank you.
Okay, so welcome back everybody. Welcome back to the Emergency Psychiatry Lecture Series. I'm Dr. Swaleha Mujawar, Assistant Professor. And today we are going to learn about depressive stupor and catatonia. These are two very important things that you see in the emergency department, and you'll probably not be able to understand what the patient is if you don't know what this is. So knowing how to identify these two cases and a little bit on the management. So what is depressive stupor? First we'll learn about that, then we'll learn about catatonia. So depressive stupor, it is quite rare. Both catatonia and depressive stupor are rare. And what is this? So do you know what stupor is? What is stupor? कोई idea है? Confused state or confused से ज़्यादा it is an unreactive state and a patient is not reacting to the external stimulus but इतना नहीं है कि वो कोमा में जा रहा है तो it is something in between delirium and coma. So stupor though is the same as the stupor that you know, and when it occurs in the form of depression या along with depression, तो उसको depressive stupor बोलते हैं. Basically, when a patient is depressed, तो patient says कि हाँ कुछ काम करने का मन नहीं करता है, बेड से उठने का मन नहीं करता है, तो दिस इज साइकोमोटर रिटार्डेशन जो हम लोग बोलते हैं. So sometimes when the depression is very severe and there is a profound psychomotor retardation, there might be mutism, there might be nearly complete lack of responsiveness, then this is called as depressive stupor. कि डिप्रेशन में उसको हिलने का भी मन नहीं कर रहा है एंड द पेशेंट इज नॉट रिस्पॉन्डिंग एट ऑल to the external stimulus. It is rare, it is life threatening, and it often requires intensive medical and psychiatric intervention. So that is why we are learning this today. So just a little bit about depression. What is major depressive disorder or depression? It is a common mood disorder that affects millions worldwide. While it is typically characterized by symptoms like sadness, fatigue, loss of interest, it can also manifest in a more severe form, that is depressive stupor. So basically this is a extremely severe form of major depressive disorder. So what are the key characteristics of depressive stupor? One is lack of movement and prolonged stillness. So like I said, patient says कि बेड से उठने का मन नहीं करता है या कुछ करने का मन नहीं करता है, तो patient is not moving at all. कुछ करने का मन नहीं is like the severe वाले फॉर्म में अगर जाए तो हिलने का भी मन नहीं करता है. तो देर इज एक्सट्रीम immobility, there is a state of prolonged stillness, and this is there for extended periods of time. Mutism, what is mutism? A complete absence of speech. It is a defining characteristic of depressive stupor. Individuals may appear unresponsive to verbal cues. जो आप ग्लास्को-गोमा स्केल लगाते हैं तो verbal cues में भी patient does not respond, unable to communicate verbally. ओके, सो दिस इज अगेन द सिवियर फॉर्म. जैसे डिप्रेशन में पेशेंट सेज कि किसी से बात करने का मन नहीं करता है, या देर इज डिक्रीज सोशल इंटरेक्शन, देर इज डिक्रीज्ड स्पीच इन डिप्रेशन. बट टेक इट टू द वेरी सिवियर फॉर्म और द मोस्ट एक्सट्रीम फॉर्म, इट इज म्यूटिज्म. There is also emotional withdrawal and numbness. So individuals in a state of depressive stupor experience profound emotional detachment, often feeling emotionally numb and withdrawal from their surroundings. So again, this is again a part of depression. So patient feels emotionally nothing or maybe very, very severe sadness. There is severe psychomotor retardation. So this refers to a significant slowing of movement and responses, making it difficult for individuals to perform even the simple of the tasks. So what are the key characteristics? Lack of movement, mutism, emotional withdrawal, and severe psychomotor retardation. So if a patient comes to you with these characteristics, always think about depressive stupor also. So what are the underlying causes? Why does this occur? So like all psychiatric illnesses, it has a biopsychosocial etiology. So we'll look at the biological, psychological and social factors. So what are the biological things? There are imbalances in neurotransmitters. So the most common neurotransmitter associated with depression is serotonin, but dopamine and norepinephrine are also disturbed. These are the chemicals that regulate mood, motivation, energy, and a deficiency can lead to extreme lethargy and withdrawal, which is seen in this condition. So you have three neurotransmitters, serotonin, dopamine, norepinephrine in your brain, which are very, very less. And this leads to depressive stupor. Psychological factors like trauma, some abuse, psychological or physical, or loss of some loved one. This can also trigger depressive stupor. Prolonged stress can also disrupt the brain stress response. The hypothalamic pituitary response, which is the stress response, that also gets disrupted after prolonged stress. So it also contributes to the development of this condition. Social factors like social isolation, lack of social support can worsen depressive symptoms and increase the risk of depressive stupor. So you'll see that these patients lack strong social network and they struggle to cope with stress. They're not able to seek help, and this further isolates them. So these are again the things probably in history which you will find that there is some trauma, there is some social isolation, and there is some stress. So again, if the stupor is occurring after a period of stress or trauma, again you should think about depressive stupor. Now coming to the diagnosis and treatment. So in differential diagnosis, a thorough evaluation is crucial. So we have to rule out other causes because like I said, stupor is a very vague symptom or a very big symptom in which there can be other differential diagnosis. The most important is a neurological disorder. So you need to do a thorough CNS examination, rule out any neurological condition, ask about substance use in history because some substance withdrawals also can cause stupor, and of course any other medical condition. So this process involves gathering a comprehensive medical history, a physical examination, any relevant lab test you feel like do you need to send serum electrolytes, do you need to get a CT, MRI done, and the goal is to identify any underlying medical issues that might be contributing to the patient's symptoms, because a lot of times we feel और you'll see emergency में कि पर्चा है patient के पास कि depression का patient है और just ये कर दे कि बस इसको और कुछ तो हो ही नहीं सकता. So this is what we want कि हाँ patient might present with depressive stupor, but we need to rule out other causes also. So in medical evaluation, assessing physical health is critical as some medical conditions can also present with symptoms similar to depressive symptoms. So we have blood tests like electrolytes. So serum electrolytes, so definitely, if even if the patient is a psychiatric patient, sending serum electrolytes, I feel not even in depressive stupor. All cases, I think a serum electrolyte is very important because it is a life and death situation. If the electrolytes are disturbed and if you don't treat it immediately, then the life is at risk. Thyroid functions are also important, and of course medically you all know better actually, so what tests to send and how to rule out all other medical illnesses. Now coming to catatonia. So this is also a very rare syndrome. In fact, it used to be very common in the uh, historical or probably 30-40 years back, but now it is very rare, and we have a case of catatonia actually in the ward. So if you want to see, Dr. Ria or Dr. Shamashish will actually take, and it is very rare. So it is good you can actually go and see the patient, and maybe you will understand this catatonia much better after seeing the patient. So what is catatonia? It is a neuropsychiatric syndrome characterized by abnormal movements, behavior and unresponsiveness. So it can occur in various psychiatric conditions but also in medical conditions, including schizophrenia, mood disorders, medical illness. So that is why we have taken this class for you, because again there is a very big overlap between medical causes and psychiatric causes leading to catatonia. And catatonia again is a symptom, just like stupor. It can have a very long range of differential diagnosis. So first we'll see how to identify catatonia, and then of course the treatment. So by definition, catatonia is a unique syndrome characterized by unusual movement problems. So movement is the key word here. There is abnormalities in movement. So patient might freeze in places, resist movement or mimic others' actions. This can lead to a wide range of clinical presentations. So, catatonia isn't tied to just one mental illness like schizophrenia. It can actually occur in bipolar also, it can occur in depression also, and the presence of catatonic symptoms significantly impacts the treatment also. And what is the distinguishing factor? It is crucial to differentiate catatonia from other symptoms. So a careful evaluation of history and specific behavior is essential, and differentiating catatonia is very, very important. So the key symptoms of catatonia that you have to keep in mind. One is immobility. So immobility again, catalepsy or stupor. So patient can have posturing for very, very long time. So patient will assume one single posture for a very long time, and this assuming posture for a long time can be again so severe that the patient is unresponsive. Mutism is again there in catatonia also. Posturing is there. Posturing means holding a specific position for for an extended period, even uncomfortable. So for our patients, we usually take their hand and we put it over their head. So in normal patients, this is a very uncomfortable position. And even if you put it there, normal patients will take it down. But in these patients, catatonic patient, they might hold it for hours also. They might not take it down. Another very important thing seen in catatonia is waxy flexibility. So what is waxy flexibility? That their limbs are like wax. You can move them very easily without any resistance from the patient. So again, when you're taking it to uncomfortable position, most patients might resist it. Like if you take it on the other side or something, they might either feel pain or uncomfortable. But these patients, their limbs are so flexible that you feel like you're actually moving a wax figure or a wax limb. So these are some symptoms. So we have immobility, we have mutism. These were there in stupor also. But posturing and waxy flexibility are seen specifically in catatonia. Now coming to some other additional features. One is negativism. So negativism is very different from mutism. Negativism means resistance to instructions or attempts to move them. So on one hand, some patients might be super cooperative that you are able to move their limbs like wax, but some patients will resist each and everything. So whatever instructions you are giving them, they are doing actually the opposite or they are not doing it. So this is negativism. Echolalia, echopraxia. Echolalia is the repetition of words. Echopraxia is the repetition of actions. So whatever you are saying or whatever you are doing, patient will mimic this. So echolalia, echopraxia again seen in catatonia very, very commonly. And according to these symptoms, then we have the types of catatonia. So we have stupor and mutism. So in this, there is extreme immobility, lack of responsiveness. Individuals remain completely still and they are unable to communicate due to mutism. Sometimes patient can be agitated also. So it is not necessary that the catatonic patient will be lying or not moving at all. Patient might be actually aggressive. There can be excessive motor activity ranging from restlessness to agitation to disorientation. So these patients might pace, they might exhibit repetitive behavior, so they might do one action again and again and struggle to control their movements. Negativism we've seen is a resistance to instructions and suggestions. Individuals may refuse to cooperate with requests or actively resist any attempts at movement or interaction. And then we have again echolalia, echopraxia, this you know. So these are the types of catatonic symptoms. So it can range from anything from zero movement to a lot of movement. So it's actually a spectrum. Patient can do anything in between and all these will constitute catatonia. So what are the different disorders in which catatonia can occur? We as psychiatrists, we see it most commonly in schizophrenia. In fact, a type of schizophrenia is called as catatonic schizophrenia. Sometimes it can occur in mood disorders also, like bipolar disorder, major depressive disorder, but it can also occur in neurological and medical conditions. So neurological and medical conditions like autoimmune diseases, substance withdrawal. So always keep in mind that this can also be a cause of catatonia. So in causes, we have neurobiological causes. So catatonic symptoms can arise from disruptions in brain chemicals like again dopamine. So dopamine was common in stupor and catatonia, but here we have GABA and glutamate. In fact, GABA and glutamate are the new research molecules. Every research is now focusing on GABA and glutamate. So these are abnormal. These neurotransmitters regulate the brain activity and communication. And imbalances can lead to unusual movement patterns and changes in thinking. So this is the neurobiological cause. There can be psychological causes again like trauma, stress, psychosis. These experiences can significantly impact the brain function and increase the risk of developing catatonia. Medical factors. So a lot of medical factors, a range of medical factors can trigger catatonic symptoms like infections, metabolic disorders, and again substance abuse. So that is why a thorough medical evaluation is very, very important to rule out all other causes of catatonia. Coming to treatment, so what are the types of treatments available? One is pharmacological interventions. So we give medications like antipsychotics and benzodiazepines. They can help manage the symptoms. Antipsychotics are usually given when there is agitation and some psychotic symptoms like delusions or hallucinations, while benzodiazepines, they usually decrease the anxiety and muscle stiffness. So depending upon the patient's symptom, we give the treatment. So the patient that we have in our ward, we are giving both uh, antipsychotics like olanzapine and we are giving benzodiazepines like lorazepam. So these are the two treatments that she is receiving. A very effective treatment is ECT, the electroconvulsive therapy or shock treatment, which is colloquially known. But again, ECT has a lot of uh, problems in the form of one, we have to get a anesthesia clearance done, and second, it is not very well received by the patients and the relatives because they feel that, oh, you're giving shock treatment, even though it is very, very effective for severe catatonia, especially when other things have not worked, but still it is becoming very rare and usually it is not given. It involves a brief seizure using electrical currents, and this can improve brain functions. It reduces catatonic. It is very, very effective, but unfortunately very rarely done. Sometimes psychotherapy also works. So supportive therapy, cognitive behavior therapy can help individuals cope with catatonia. CBT is becoming like the most common therapy or the most well received therapy again. So it focuses on identifying and changing negative thoughts and behaviors, while supportive therapy offers emotional support and guidance. Last but not the least is the multidisciplinary approach where you guys come in. So treating catatonia often requires a team of professionals like psychiatrists and neurologists. This collaborative approach ensures that the individual receives the most appropriate care for their needs. So, not just a psychiatrist, a whole team, if they are treating, then it is better. So now that we know what is depressive stupor, what is catatonia, let us understand and differentiate between the two. So depressive stupor is a severe form of depression characterized by extreme withdrawal, inactivity and lack of responsiveness. Individuals may appear unresponsive to their surroundings and struggle to engage in basic activities. Even eating and bathing, getting ready, all these things also will be absent. Catatonia, on the other hand, is a state of immobility or excessive motor activity, often accompanied by odd movements, negativism, echolalia. So while both conditions involve significant disruptions in motor behavior, they differ in their underlying causes, which we have seen, and associative symptoms. For instance, catatonia can be triggered by various medical conditions, while depressive stupor is primarily linked to depression. Additionally, while catatonia may involve periods of excitement or agitation, in depressive stupor there is always extreme lethargy and passivity. So depressive stupor will never present with excitement or increased activity. So similarities are that they both involve psychomotor retardation, mutism, and impaired responsiveness. But differences are that catatonia will have more movement abnormalities like waxy-flexibility, posturing, and depressive stupor will have very severe and specific depressive disorders and depressive symptoms which are not present in catatonia. And again, treatment wise also, in depressive stupor, we'll give antidepressants, we'll give psychotherapy. Sometimes ECT might be required if medications are not working or they are ineffective. In catatonia, benzodiazepines like lorazepam are used to manage the catatonic symptoms. ECT might also be considered in severe unresponsive cases. Prompt intervention is crucial to prevent any complications like autonomic instability, and death can occur in these cases. So that is why it is very, very important to treat them and treat them very quickly. So the importance of early intervention is very, very important. Depressive stupor and catatonia, they are actually psychiatric emergencies. Both depressive stupor and catatonia require immediate attention, immediate intervention. So time should not be wasted here. Prompt intervention leads to optimal outcomes. So like most illnesses, if early intervention is done, then there are less complications and recovery is also faster, recovery is better. Role of diagnosis and assessment. So accurate diagnosis is very important. Medical evaluation very, very important to rule out medical conditions. So in conclusion, for understanding and managing depressive stupor and catatonia, we need early identification and treatment. So a prompt diagnosis and intervention are crucial. Specialized care and support. So we need multidisciplinary team. We need neurologists. We need your emergency professionals. We need psychiatric professionals. So we need a team approach here, and we also need continued research to understand better what these conditions are, and also to develop some effective treatment strategies, because current strategies are, yes, there, but they are not effective in managing all patients very effectively. So in conclusion, I would like to say that catatonia is a complex neurological neuropsychiatric syndrome with significant implications on both mental health and physical health. And understanding this is very, very important for optimal care. That is why we are trying to teach you. Once you know what these things are, you will be able to identify, you will be able to treat this better. So with this, I end this lecture. If you have any doubts, so welcome again, continuing with the same emergency psychiatry series. Now we are going to learn about delirium and organic mental disorders. So I am Dr. Swaleha Mujawar, Assistant Professor, and I'll be teaching you about this topic. So what we are going to cover, what is organic psychiatry, what is delirium. So in delirium, we are going to learn about introduction, clinical features, diagnosis, and management. So as psychiatrists, we always say कि organic case है, organic case है. तो organic case में आता क्या है? ठीक है? So classification of organic mental disorders can be acute organic mental disorder, chronic, then organic amnestic and other organic. इसमें से भी the first two, acute and chronic, are important because these are the cases which you're commonly going to see. So if the organicity is acute, the patient is mostly delirium. If the patient presents with a chronic organic mental disorder, that comes under dementia. So as emergency psychiatry doctors, you will be seeing mostly acute cases. So that is why we are going to learn about delirium today. Delirium, you're going to see this everywhere if the patient is post-op, a medical patient, neurological patient. This is something which you're going to definitely see. So whenever a patient comes to you and you're trying to assess the patient, first understand what is delirium. So in introduction, I would like to say that delirium is a transient global disorder of cognition. Basically, cognition is getting impaired. It is a medical emergency and it is derived from the Latin word which means off the track. Why is it important? Why is it an emergency? Because it leads to increased mortality. We need a lot of nursing care for this. And in future, it leads to failed rehab, it leads to delayed discharge. So treating this is very, very important. And a lot of times it goes unrecognized also. Many cases are undiagnosed. Approximately 40 patients of elderly with delirium are sent home. And sometimes it is misdiagnosed as depression. Again, around 40 cases are misdiagnosed. So then they are not treated well. Looking at the epidemiology, 20% of patients of general ward have delirium, 30 patients in elderly because it is more commonly in elderly, and we don't know about the community incidence, but maybe after 85 years of age the incidence increases to 10%. If the patient is more than 65 with dementia, again the incidence increases. Again, in special populations, so long-term residents, surgical patients, cardiac surgical patients, very, very high chances. Again, ortho ward, so patients with hip fracture, more than half patients with hip fracture develop delirium. Again, if the patient has more than 65 years of age and admitted in the ICU, the chances are 70%. This is very, very high. So this is also called as ICU psychosis. When delirium occurs in the ICU, the diagnosis made as ICU psychosis. Palliative advanced cancer patients, 88% chance. So very, very high chances of this occurring. So as psychiatrists, we follow diagnostic and statistical manual. So what is the DSM definition of delirium? One, we need a disturbances in consciousness. So patient is either drowsy or going in and out of sleep. So there is disturbances of consciousness with reduced ability to sustain or shift attention. Then there is a change in cognition or development of a perceptual disturbance not explained by any other condition. And there is a disturbance which develops over a very short period of time. That is why this comes in acute. Because period of symptoms or development of symptoms is very short, probably a few hours or a few days, not more than that. And this fluctuates, very, very important. So in between the patient might be normal and in between patient might go into delirium again. So delirium is a problem in consciousness and cognition which occurs acutely and it fluctuates. So these are the core features of delirium. Other clinical features that we've seen, it is acute in onset, develops over hours or days. Onset might be abrupt also. A prodromal phase might be present. So before the development of overt symptoms, Some gradual onset symptoms might be seen in the form of fatigue or daytime somnolence, decreased concentration, irritability, restlessness, anxiety, mild cognitive impairment. So these might be present in the prodromal phase in some patients. Fluctuation is very, very important. And this is a very unpredictable fluctuation. Patient can go in and out of delirium without any stimulus, or even during your interview patient might become oriented to time, place and person and then become disoriented again. It is intermittent. Mostly it worsens in the night. This is called as sundowning. So when the sun goes down, the symptoms get worsened. There are periods of lucidity. So in between when the patient is normal, these are called as periods of lucidity. Psychomotor disturbance can be present. Patient can be restless, agitated, or patient can be lethargic or inactive. So according to this, patient can have hyperactive delirium or hypoactive delirium. So these are the two types of delirium that the patient can have. So disturbances in consciousness, patient can be hyper alert, that is overstimulated, or can have normal alertness, can be lethargic, can be comatose also. Inattention is basically a reduced ability to focus, sustain or shift attention. So you will see this in the form of easy distractibility. So when you're talking to the patient, the external stimuli might interfere. तो कहीं दूर कुछ तो आवाज होता है तो patient might get distracted and shift their attention to that voice. It may account for all cognitive deficits also, because attention is very, very important. There is a disruption in sleep-wake cycle also. So patient might have fragmented or disturbed sleep. Patient can have vivid dreams, nightmares, and this they might have difficulty distinguishing from real perception. So they feel whatever dreams that they are having is actually true. Patient might be somnolent इन द डे टाइम, और ही में फील कि ऐसा लग रहा है सपने जैसा हो रहा है, ड्रीम लाइक हो रहा है. इमोशनल डिस्टर्बेंसेस, फियर, एंजाइटी, डिप्रेशन कैन अकर. There are some disturbances of thought also. So abnormalities in the form and content of thinking. So their thinking is not organized. It can be bizarre or illogical also. So patient might be just talking irrelevantly. Uh, Psychotic content can also be seen. So delusion or persecution are very, very common. Judgment and insight is poor. In fact, when I was working in Mumbai, there was a patient in the ICU who actually killed the other patient. So it had become like a very big incident. Patient was in delirium, a patient was not treating, and then he took a saline ka rod and we lost another patient just due to delirium. So this can actually escalate very quickly. So you have to be very careful. There can be disorders in language. So language can be slow and slurred. Patient can have word finding difficulty, difficulty in writing. There can be disorders of memory and orientation also. So there is poor registration, recent remote memory. So what they had for lunch or dinner. Yeah, some people will come and meet them, but they will not remember. Confabulation can occur, and disorientation to time, place and person. So this is very, very commonly seen. Perceptual disturbances. So patient can have distortion like macropsia and micropsia. Macropsia means everything will appear big to them. Micropsia means everything will appear small to them. Derealization, depersonalization, कि जो भी हो रहा है वो रियल नहीं है. Illusions, so misinterpretation of external stimulus, like there will be a wire kept but patient will see a snake in the form of wire. Hallucinations usually are visual, often occur during the night when they are not able to see properly. They can be simple, they can be complex. Auditory hallucinations, they might hear simple sound, music, voices. Tactile hallucination, even though they are very uncommon, but they can also occur in delirium. Now, does delirium present similarly in all patients? Like we have seen a long list of signs and symptoms, but it is not necessary that all of them will be present in all patients. There will be a permutation and combination, and according to these, we can classify them into three clinical variants: hyperactive, hypoactive, and mixed. So in hyperactive, patient is restless, agitated. Autonomic arousal can also be there. In hypoactive, patient is lethargic, drowsy, they might be confused. And this hypoactive type of delirium is actually misdiagnosed or underdetected, because hyperactive, everybody is vigilant towards the patient also, but if the patient is hypoactive, sometimes even we as doctors do not notice it. Mixed means patient has hyperactive, hypoactive, both symptoms. Now we have some screening tools. So as part of the assessment, we can use MMSE, which we use for mostly for dementia, but we can use it in delirium patients also. We have a scale called as CAM, Confusion Assessment Method. So you can use this scale. MOCA is again a scale, Montreal Cognitive Assessment Scale. So these are a few scales that you can apply. Investigations, long list. Anything under the sun can cause delirium. So we have CBC electrolytes, kidney function test, calcium, liver function test. So according to the patient's symptoms, you can send the investigations. And always remember, it is a medical emergency. So very quickly just do a physical examination. More importantly, a neurological examination. Check for hydration and nutritional status. If possible, correct it as soon as possible. Evidence of sepsis, if it is there, you need to treat it immediately. If alcohol abuse, alcohol withdrawal is there, again, treating it as soon as possible will save the patient's life. So what are the risk factors which put the patient at risk for delirium? Dementia is one of the most consistent risk factor. So if the patient has underlying dementia, then the chances are 25 to 50%, and it increases the risk by 2 to 3 times. So delirium on dementia can occur, and in elderly people, other risk factors are also there. So they are physically very fragile, they have multiple medical problems, they are very prone to infections also, more commonly chest and urine infection. They are also on a lot of medication, and polypharmacy puts the patient at risk for delirium. So a lot of times just stopping all the medication is the treatment for delirium. Sensory impairment, metabolic disturbance, long bone fractures, general anesthesia, these are all risk factors for delirium. Now, what are the causes? So, severe physical mental illnesses which interfere with the normal metabolism of function of the brain can be a cause. So we have some mnemonics if you want to learn the causes. So we have infections, withdrawal, acute metabolic acidosis, renal failure, trauma, any CNS pathology ranging from epilepsy to hemorrhage, hypoxia, B12 deficiency, thiamine deficiency, a lot of endocrine causes, mostly occurring from thyroid, parathyroid, sometimes glucose fluctuations can also occur, vascular causes like stroke, MI, heart failure, toxins like digitalis toxicity, antidepressant toxicity, anticholinergic steroids, recreational drugs, heavy metal poisoning. So these are the long list of causes for delirium. Pathophysiology is not very well understood, but we feel that it is mainly because of reversible impairment of the cerebral oxidative metabolism. So basically brain का ऑक्सीजन सप्लाई ठीक से हो नहीं पा रहा है, मेटाबॉलिज्म ठीक से हो नहीं पा रहा है, प्लस some neurotransmitter abnormalities also. The neurotransmitter most commonly involved, I'm sure ये नीट में भी तुम लोगों ने पढ़ा होगा वैसे, but acetylcholine. So if you want one neurotransmitter for delirium, that is acetylcholine. And that is why anticholinergic drugs cause delirium very commonly. They cause acute confusional state, and Alzheimer's may be cholinergic abnormality hoti hai, so they are also more prone for delirium. Excess dopamine can also cause delirium. Excess serotonin can also cause delirium. There are some inflammatory mechanism also. So interleukin 1 is increased, stress reaction, sleep deprivation, disruption in the blood-brain barrier. These are also possible mechanisms. So now coming to the treatment. What can you do? We have non-pharmacological approaches and pharmacological approaches. And remember, non-pharmacological approaches are also equally important because we keep focusing on the medicines. But remember, assessing safety is very, very important. If you feel there is a harm to self or other, restrain the patient. Physical restraints can be applied. Make sure there is adequate oxygenation, electrolyte balance, adequate hydration. Correct the sensory deficits. Manage pain. Sometimes pain management actually is a treatment for delirium. Make sure there is a normal sleep pattern. Optimize communication. So have a very calm and supportive approach. Avoid confrontation. We use a lot of reorientation strategies also. So you tell the relatives कि बार बार उनको time बताओ, बार बार उनको calendars बताओ कि आज ये दिन है, आज Wednesday है, अभी 2 बज रहे हैं दिन के. This also helps a lot in this. Staff consistency भी important है. Involve friends and family. Promote some meaningful activities because ICU वगैरह में they have nothing to do. Sometimes just giving them activities also helps. Provide education about the delirium to the relatives. If the patient is very old, try to mobilize them, give them a proper routine, encourage self-care, optimize the environment. तो बहुत ज़्यादा सेंसरी स्टिमुलेटेड एनवायरनमेंट नहीं होना चाहिए. हम बोलते हैं कि डार्क रूम जो थोड़ा काम हो, जहाँ पे मिनिमम नॉइज हो, लाइटिंग भी अच्छी होनी चाहिए, और it reduces misinterpretation, promotes sleep, provide familiar objects, familiar people, and evaluate the response to management. So pharmacological management, always remember psychotropic medication should be reserved for patient जो बहुत ज़्यादा distress में है due to agitation or psychotic symptoms. In the absence of psychotic symptoms causing stress, treatment of hypoactive delirium with psychotropic medication is not recommended. तो पेशेंट को अगर जरूरत नहीं है तो एंटीसाइकोटिक्स नहीं देना है. Psychotropic medications are not indicated for wandering also. We want to keep the patient at minimum medications at the lowest dose. That is our main aim. So what are the types of medications that we commonly use? Antipsychotics are more commonly used. Typical antipsychotics like haloperidol. Haloperidol injectable form में भी आता है तो वो अच्छा है. Atypical में we have olanzapine. Olanzapine भी injectable form में आता है. So these are the two commonly used drugs. Benzodiazepines, again lorazepam, diazepam we use. Cholinesterase inhibitors and other medications. So, haloperidol has the advantage that it is less anticholinergic, it is less sedating, and we have a lot of formulations available. Like injectable में भी आता है, oral में आता है, syrup आता है. So whatever you want to do, just remember start at very very low doses. So haloperidol is given at 0.25 to 0.5 mg either once or twice a day. But whenever you're giving haloperidol, always remember there is a risk for QTC prolongation. तो ventricular arrhythmias होना बहुत risky होता है, तो get a baseline ECG done. That is always helpful. Extrapyramidal side effects can occur like acute dystonia, Parkinsonism, akathisia. Neuroleptic malignant syndrome can also occur. ऑर्थोस्टैटिक हाइपोटेंशन हो गया तो पेशेंट कैन फॉल बाथरूम वगैरह में, दे कैन हैव इंजरीज. ओवर sedation should also be kept in mind. Atypical antipsychotics mein, like I've told you, olanzapine is there. Sometimes we use risperidone also, we use quetiapine also. So these are all atypical antipsychotics. Atypical antipsychotics का फायदा ये है कि extra pyramidal side effects नहीं होते. ठीक है, तो कुल बट यही याद रखो, ओलैंजापिन हैज एंटीकोलिनर्जिक प्रॉपर्टीज, तो वो थोड़ा प्रॉब्लम हो सकता है. बाकी प्रॉब्लम्स है मेटाबॉलिक सिंड्रोम, तो ग्लूकोज डिसरेगुलेशन, इंक्रीज इन कोलेस्ट्रॉल, ये सब हो सकता है. All atypical antipsychotics have increased risk of stroke or mortality in dementia patients. So keep this in mind. Keeping this in mind, हम haloperidol ही use करते हैं. But if you want to use atypical antipsychotics, you can use risperidone 0.25 mg OD or BD, olanzapine 1.25 to 2.5 mg per day, quetiapine also 12.5 to 50. So these are very low doses actually, and they are preferred in patients with Parkinson's disease or Lewy body dementia. Other treatments, we have benzodiazepines, especially if there is alcohol withdrawal, so फिर we prefer benzodiazepines. But remember, benzodiazepines, they themselves exacerbate delirium. So if you can avoid them, avoid them. But if the patient has alcohol withdrawal, then it is a treatment of choice. We can give cholinesterase inhibitors also. We can use other drugs like trazodone, which is an antidepressant, but we very rarely use them. It has a poor prognosis, especially in elderly. So always taking a high risk consent, explaining to the relatives also that there will be a lot of functional disability, the hospital stay might increase, and mortality, 1 month mortality is 16%, 6 month mortality is 26%, and one or two symptoms might persist even after 6 months. So prognosis a little bit guarded, talking to relatives always helps. What can you do in outpatient care? Patient will remember कि delirium में क्या हुआ था, मैंने क्या किया था. तो educate the patient, educate the family members कि future में risk हो सकता है इसका. Give the patient at least 6 to 8 weeks for full recovery, and some cognitive effects might not resolve. So we can't tell the patient कि 100% improvement होगा. उतना थोड़ा बहुत समझाना बहुत जरूरी है. Okay? So with this, I end this lecture. If any questions you want to ask, the questions are welcome. Okay, so good morning. Today we are going to learn about emergencies resulting from substance intoxication. So this is basically a emergency psychiatry lecture series. So we'll be telling you how to manage the cases or what you can do from an emergency point of view or in the emergency. Okay, so I'm Dr. Swaleha Mujawar, assistant professor, and I'll be teaching you about what emergencies can happen. So see, substance intoxication emergencies. So we'll just look at a comprehensive way in which substance intoxication emergencies can present. So see, they are very common occurrence in the healthcare settings, and they do pose a significant challenge for clinicians. Whenever a patient comes in intoxication, it is a challenge. These emergencies involve individual experiencing impaired functioning and safety risk due to the effects of various substances. So this presentation will provide a comprehensive overview of substance intoxication emergencies. So we'll be covering key aspects such as the common settings, clinical presentations, and some management strategies. So, one way in which a patient can present to you is substance-induced psychosis. So, this is quite a serious condition. So, what are the substances which can cause psychosis or can trigger psychosis? So, one is cannabis. The most common in which the patients present to us mostly is cannabis. So it can trigger paranoia, hallucinations, and altered perceptions. So this is how patients can present. Less commonly we see other substances also, like if a patient has taken amphetamine, so patient will come with hyperactivity, agitation, again psychosis with paranoia and delusions. Cocaine we see less commonly in our settings, but again patient can have paranoia, hallucinations, violent behavior, hallucinogens like PCP. So again, very uncommon here, but after taking PCP, patients do have vivid hallucinations and altered sensory perceptions. Synthetic cannabinoids are also becoming very common, so in the form of gummies or different types of sweets, and in this area like bhang and everything is also quite common. So that can also mostly cause severe anxiety and agitation, but proper psychotic hallucinations can also occur. Alcohol less commonly causes psychosis, but especially if a patient has heavy or prolonged drinking, or patient is in delirium tremens, which is the withdrawal part of alcohol, that can also cause psychosis. And sometimes some prescription drugs. So patient can misuse some drugs which mostly contains stimulants. So sometimes we give stimulants for ADHD or depression, or people give opioids for pain or cough. So all these things patient starts taking and then starts misusing. So that can also trigger psychosis. So what are the symptoms? So delusions. Delusions, by definition, they are false beliefs that are not based in reality. So, delusions of persecution, delusions of reference, that people are trying to kill me, or people are trying to plot behind my back, talking behind my back. This is what delusions are. What are hallucinations? They are sensory experiences that are not real. So patient might be seeing things, hearing things which are not there. तो पेशेंट माइट प्रेजेंट टू यू कि आवाजें सुनाई देती है, कोई मुझसे बात कर रहा है, या दिल से कि वहां पे कोई खड़ा है, या कोई एनिमल है, या कोई स्नेक है जो मुझे मार रहा है वगैरह. So this is what hallucinations are. Sometimes they might just have disorganized thinking. So difficulty with coherent thought process and communication. So this presents with irrelevant talk. So the relatives might just say कि अजीब अजीब बातें कर रहा है, या क्या बोल रहा है हमें समझ में नहीं आ रहा है. So this is disorganized thinking, which is also part of psychosis. Agitation. So restlessness, anxiety, hyperactivity. Paranoia, we all know what that is: suspiciousness, fear, mistrust of others, or just plain violent behavior. So, violence behavior can be due to paranoia, secondary to paranoia, or patient might just be violent without any reason also. Now, delirium. So, delirium also you do see a lot in emergency setting or post-op setting. Delirium is very, very common. So, what are the symptoms? Symptoms में सबसे important to remember is there is fluctuating level of consciousness. So patient is either drowsy, or patient is becoming unconscious, going in and out of consciousness. This is like the number one characteristic of delirium. Second is confusion. So again, patient might be confused where they are. Disorientation. So disorientation to time, place, and person. So patient might feel that they are at work or they are at home. Some patients say कि हम मंदिर में हैं. फिर day night disorientation होता है. They are not recognizing the family members. But all this should be fluctuating. So patient बीच बीच में normal भी हो रहा है, बीच बीच में delirium में भी जा रहा है. Individuals with delirium may experience again agitation, restlessness, या फिर slowed movements and lethargy. So hyperactive delirium, hypoactive delirium, that you have to decide. but both these things are delirium again. Other common symptoms are difficulty focusing attention, memory problem, or difficulty with language and communication. Delirium can also manifest as hallucinations, delusions, sleep-wake cycle disturbances. So you'll notice that there are a lot of symptoms which are overlapping. So in psychosis, in delirium, you will see symptoms overlapping, but main point to remember here is fluctuating level of consciousness and disorientation. That is going to differentiate it from other forms of psychosis. Then agitation and aggression. So recognizing agitation aggression is very important, because before the patient can get violent or can do some harm to some persons or some property, it is better that you identify, better that you treat as soon as possible. So agitation and aggression are different. For you guys, maybe they might be the same, but from psychiatry point of view, they are different. So what is the difference? Agitation is characterized by restlessness, that is the inability to sit still, and a heightened state of arousal. So patient is very very alert, very very aroused. A small stimulus will also lead to a lot of response from that patient. Individuals experiencing agitation may exhibit pacing, fidgeting, and rapid speech. So there is increased activity. Patient एक जगह बैठ नहीं रहा है, इधर उधर घूम रहा है, बहुत ज़्यादा बातें कर रहा है. They may also become easily startled or react impulsively. लाइक आई टोल्ड यू, एक छोटा सा भी स्टिमुलस देंगे, छोटा सा भी आवाज आएगा तो दिल भी लाइक कि क्या हो रहा है, और एकदम से जाके नहीं तो देखेंगे कि कहाँ पे क्या हो रहा है. दे आर नॉट सिटिंग एट वन प्लेस. एग्रेशन involves behavior that are intended to harm or threaten others. So aggression may definitely there will be some harm, physical or verbal harm, or some threat to the other. तो agitation mostly anxiety के towards जाता है, but aggression is again more towards psychosis, because there is some harm again. It can manifest as verbal threats, physical violence, or destructive actions. Individuals exhibiting aggression may display anger, hostility, and a lack of impulsive control. कि सडनली कुछ कुछ चीजें करने लग गए, इम्पल्सिवली कुछ एक्शंस कर रहे हैं, किसी को मार रहे हैं या प्रॉपर्टी डिस्ट्रॉय कर रहे हैं. तो दिस इज एग्रेशन. सो एग्रेशन इज डिफरेंट फ्रॉम एजिटेशन. Okay. Now, sometimes patient may present with severe anxiety or panic attacks. So again, if you look at ऊपर ऊपर से, तो सारा कुछ same ही दिखेगा. Psychosis will also look very similar to anxiety or panic attacks. So you have to differentiate it. So again, anxiety or panic attacks can also be substance induced. So what are the substances that can cause anxiety? One is stimulants. So stimulants again like amphetamine or cocaine, they can induce anxiety, panic attacks, or a heightened state of arousal. Hallucinogens like LSD, psilocybin. Psilocybin are the mushrooms basically. They can also trigger anxiety, panic attacks, and intense psychological distress. Cannabis, particularly high potency strains, can cause anxiety, panic attacks, and paranoia in some individuals. Alcohol withdrawal. Alcohol, because per se is a CNS depressant, but when the patient goes into withdrawal, patient can have severe anxiety, panic attack. Tremors are like the more commonly seen, and very early stages of withdrawal में tremors दिखने लगेंगे, and very early stages में anxiety भी दिखने लगेगा. So that means that you need to treat the patient. अब ये हो गया इंटॉक्सिकेशन स्टेज में. अब विड्रॉल सिंड्रोम्स कैसे प्रेजेंट कर सकते हैं? तो पेशेंट कैन स्टे प्रेजेंट टू यू इन अर्ली स्टेज, इन मिडिल स्टेज, एंड इन लेट स्टेज. Okay, so in early stage, Withdrawal is characterized by like tremors, I've told you. Patient can have sweating, anxiety, insomnia. So these are all symptoms of withdrawal. These symptoms typically appear within a few hours to few days after the last use of substance. So the most important question that you need to ask is ki when did you take the substance? If the patient has immediately taken the substance, then the patient is in intoxication. If a few hours have passed by, then the patient is in withdrawal. So you need to know the exact time कि कल रात को लिया था, पर कल रात को कितने बजे लिया था, 9 o'clock लिया था, 12 बजे लिया था, उससे भी बहुत डिपेंड करता है कि वो कौन से स्टेज में है. तो यू नीड टू आस्क ऑल दीज क्वेश्चंस. ओके, मिडिल स्टेज में क्या हो रहा है? एज विड्रॉल प्रोग्रेसेस, इंडिविजुअल्स में experience more severe symptoms. So severe symptoms में आता है हमारे hallucinations, seizures and delirium tremens, which is specific to alcohol. These symptoms can be life-threatening and require immediate medical attention. So वही है कि psychiatrist को you are calling, but immediately if you can do something, give a sedative or give some treatment, so that is also better. In late stage, there is a gradual decrease in intensity because body थोड़ा बहुत recover करने लगता है, body adjust करने लगता है. So in late stage, again the symptoms are decreasing. However, individuals may continue to experience craving and some residual effects. तो ये late stage आता है हमारे weeks or months में. तो here तो maybe the patient might not even present to the emergency, but early and middle stage में तो emergency में present करता है, and you need to treat them also. Like for example nicotine withdrawal symptoms. So nicotine withdrawal में starting में आएगा decreased sleep, anxiety, craving. लेटर स्टेजेस में यू सी वेट गेन, यू सी कफिंग, ये सारी चीजें होती है. तो यू नीड टू एक्चुअली डिसाइड कि व्हाट स्टेज द पेशेंट इज इन, because that will decide the management strategies. Now another very very important emergency is suicide, because in psychiatry there are only two emergencies: suicide and homicide. And by homicide I mean the violent behavior. So suicide also should be taken very very seriously. Suicidal ideation and self harm requires immediate attention, because the patient we can lose the patient's life because of this. So immediate psychiatric evaluation is required. A thorough psychiatric evaluation is essential to assess the severity of suicidal ideation and self-harm. This evaluation helps determine the underlying cause and guides the development of a treatment plan. So why the suicidal ideations are happening, what is the underlying cause, and that is important. And then treatment and support. So individuals experiencing suicidal ideation or self-harm need immediate treatment and support. This may involve hospitalization, close observation by family or friends, or if they are not ready to get hospitalized, at least participation in a structured support programs. So a lot of community support programs are also available. Medications such as antidepressants or mood stabilizers may be prescribed. So वही है, अगर patient admit नहीं हो रहा है तो at least we can prescribe some antidepressant, some mood stabilizer. But if a patient has suicidal ideations, you need to get a psychiatric evaluation, and immediately a psychiatrist needs to see the patient. Now, another very very important way in which a patient might present to you is serotonin syndrome. And this is something जो एकदम से दिमाग में नहीं आता है, या एटलीस्ट तुम लोगों के दिमाग में नहीं आता है कि if a patient is coming to you, that it might be serotonin syndrome. So you need to know what are the symptoms. One is hyperthermia. ये I don't know if you are able to see this. because थोड़ा सा ये है. So hyperthermia. So serotonin syndrome can cause dangerously high body temperature. This is because the excess serotonin in the body disrupts the body's temperature regulation system. So that is why the first and foremost presentation of serotonin syndrome is hyperthermia. Second is agitation. So people experiencing serotonin syndrome, they may feel restless, anxious, agitated. This is due to the overstimulation of the nervous system by the excess serotonin. ठीक है, तो पेशेंट अगर फीवर के साथ आ रहा है और एजिटेशन के साथ आ रहा है, तो देन यू शुड थिंक one of the differential diagnosis can be serotonin syndrome also. Patient can have tremors also. So involuntary muscle shaking or tremors are a common symptom of serotonin syndrome. This occurs again because of excess serotonin affecting the muscle's ability to function properly. And this can also be one of the reasons for fever also, because बहुत ज़्यादा muscle contraction हो रहा है, that is leading to increase in temperature. Sometimes seizures can also occur. तो अगर बहुत ज़्यादा उसने serotonin वाले drugs खा लिए, तो in severe cases serotonin syndrome can cause seizures. These are caused by uncontrolled electrical activity in the brain, often triggered by the overstimulation caused by excess serotonin. And then autonomic instability भी होती है. तो excess serotonin can disrupt the body's autonomic nervous system, leading to rapid heart rate, excessive sweating, fluctuations in the blood pressure. So all these are symptoms of serotonin syndrome also. So asking history is very, very important, that what drug the patient is taking. The patient is on some drugs which can increase serotonin and has all these symptoms, then serotonin syndrome can be one of the causes. Now coming to management. So key management principles, a systematic approach is very, very important. So immediate assessment and action, what can be done? One is prioritize the patient's safety and stability by assessing the condition. So this includes vital signs, which you guys always take, mental state examination, which usually the psychiatrist assesses, and also seeing if there are immediate threats. So threats to other or threats to the patient himself, followed by appropriate interventions to mitigate them. So informed medication use medication judiciously by symptoms, considering the specific substance involved. So substance to substance the medication changes, and the patient's clinical presentation. This ensures safety and minimizing the potential side effects. Also addressing the underlying cause, so identifying the underlying cause. So is it intoxication, is it a withdrawal, treating the substance use disorders, managing the withdrawal symptoms, and if some coexisting medical conditions are there, then that also needs to be treated. Okay, so this is from your point of view at least. Other specific treatments, of course, the psychiatrists are going to handle, but till the psychiatrist comes, at least these are the things, assessment and treatment from your point of view. Okay, so with this, we finish the substance intoxication point of view. Any doubts, any questions?
Good morning to all. So we have a class on emergencies resulting from substance withdrawal. So substances are illicit substances like alcohol, opioid, and others. Basically, there are three conditions are associated with the substance. One is intoxication, which you have already learned, and the second is withdrawal. And in the withdrawal, there is complicated withdrawal in certain substances. So let's start with alcohol withdrawal. So we know that in alcohol withdrawal, the two neurotransmitter system which is dopamine and gamma aminobutyric acid are involved, and alcohol acts through gamma aminobutyric acid. And in the long term, when the excessive and continuous amount of alcohol is there in the brain, uh, there is upregulation of GABA receptors, and these GABA receptors are inhibitory receptors. And if one tries to abstain from the alcohol, uh, there is a biochemical reactions because of these changes in the neurotransmitter system. We will see further in the slides. So in terms of symptoms, alcohol withdrawal has mild, severe and complicated withdrawal. The mild symptoms will be moderate tremors, anxiety, night sweats, restlessness, irritability, nightmares. In severe symptoms, one can have seizure, severe tremors, increased heart rate, fever, nausea, vomiting, even hallucinations, and increased agitation. In complicated withdrawal, there are three terms known as delirium tremens, Wernicke's encephalopathy, and Korsakoff psychosis or Korsakoff syndrome. So there is a timeline to occurrence of the certain sets of symptoms, and usually it starts after 6 to 8 hours of the abstinence or quitting the substance, and it may last for 7 days in mild to moderate withdrawal, and severe or complicated withdrawal may last longer, more than 7 days. The first symptoms you will observe after 6 to 12 hours are anxiety, difficulty concentrating, palpitations, problem in sleeping, mood swings, nausea, vomiting, hypertension, increased heart rate, and increased body temperature. In 12 to 48 hours, there may be headache, body aches, continued trouble in sleeping, anxiety, sweating, strong craving of substance, lightheadedness, fever, irritability, acidity, and confusion. This 48 to 72 hours is the peak of the withdrawal, in which one can have seizure, delirium tremens, and other complications. May or may not have complicated withdrawal. It depends on the duration of the dependence, the amount the person consuming daily, and other medical conditions. And this can last up to 5 days or more days. It is important to create a plan so that these can be prevented or avoided. The last is 3 to 7 days, in which the withdrawal symptoms are now decreasing, and gradually the patient has started feeling relief, and but may still experience anxiety, trouble sleeping, racing thoughts, mental fatigue, and craving. So this is the timeline, and there is a term is known as protracted withdrawal, which may last up to 1 month or few months, which may be taken care of after detoxification in the relapse prevention phase. So lab tests required are CBC. So normal routine blood tests are required, and CBC like CBC, blood sugar, liver function test, kidney function test, lipid profile, routine microscopy of urine, gamma glutamyl transferase, which is more specific to the liver pathology, serum lipase and amylase for if the person is having comorbid pancreatitis, ultrasound abdomen or fibroscan to see the structural change in the liver. In treatment, more or less all the guidelines says first line treatment are benzodiazepines, second line treatment is carbamazepine, and thiamine is added to prevent Wernicke's Korsakoff encephalopathy. We will discuss it later. What is the role of thiamine? Alpha 2 adrenergic agonist and beta blocker in association with benzodiazepine in severe autonomic hyperactivity. The central autonomic hyperactivity can be controlled by the drug like clonidine and propranolol. To start with detoxification, we have first choice of drug are benzodiazepine, and we are discussing here three molecules. One is diazepam, second is lorazepam, and then chlordiazepoxide. So there are two types of regime. One is fixed dose combination, and another is flexible dose combination. Flexible dose combination usually practiced in the indoor setup where patient is admitted in the ward or or in other medical setup, and fixed dose combination usually required for OPD patients and the patients in at community level. So for mild withdrawal, 5 to 10 milligram of uh, diazepam is needed for few days, like 1 to 3 days uh, is required in the milder withdrawal, and lorazepam is 1 to 2 milligram orally every 4 to 6 hours as needed for 1 to 3 days. So this SOS basis, milder withdrawals are not so cumbersome, is not so uncomfortable to the patient, so they can bear these withdrawal. Chlordiazepoxide also in low dose for few days may be required. For moderate withdrawal, the diazepam is required in dose of 15 to 20 mg 4 times a day. Then uh, after 1 day, on the second day, it can be reduced every day in certain amount, like 10 to 20 milligram QID on second day, 5 to 15 milligram TDS on third day. And if it is 15 milligram TDS, then uh, on day 4, this can be reduced to 10 milligram QID, and then 5 milligram QID. Then one can stop after day 5 or as and when needed as per the withdrawal symptoms. In severe withdrawal, 10 to 25 milligram orally is needed uh, every hour while awake until sedation is occur. Severe withdrawal can lead to delirium tremens, so higher doses are required. For lorazepam, in moderate case, 2 to 4 milligram QID, then day 3 to 4 reduce gradually to 1 to 2 milligram QID, and day 5 1 milligram BD. Then so the protocol is for all the things, all the molecules is start with higher dose, and day by day reduce the certain amount of doses every day. For example, 25 to 30, 30 or 33% of doses is reduced every day as required. This is a chart for drug dose conversion when uh, diazepam is not available, then the dose conversion chart can be used to use other molecule for substitution, uh, like dose conversion of 60 milligram of diazepam is 6 milligram of alprazolam, 150 milligram of chlordiazepoxide, 24 for clonazepam, 90 flunarizepam, 240 helazepam, 12 is lorazepam, and 64 oxazepam. So widely or commonly available molecule which we use in our clinical practice is chlordiazepoxide and lorazepam more. Oxazepam is also available, but used in lesser amount. Clonazepam is available, but higher number of tablets is required so that the person has some discomfort to taking so much of tablets. So clonazepam is not used. Clonazepam basically used uh, as anti-anxiety in psychiatric illnesses. So this is the benzodiazepine tapering regime. If the patient is on uh, 60 milligram of diazepam, so the doses can be reduced every 3 to 4 days, every 3 days. In if you see this, this will be seems to be complicated, but by and large, you can see that after third day it is reduced by 33% for 3 days, then again 25% for further 3 days, then 33%, then 50%, then stop. So this is the broader guideline, the percentage, and it depends on the molecule to molecule. One have to convert the equivalent dose to the benzodiazepine for tapering the benzodiazepine. Now this is one of the complication of severe alcohol withdrawal, and the cause is downregulation of GABA aminobutyric acid. You know that the benzodiazepines are anticonvulsants also. So if the anticonvulsant is suddenly stopped or removed, then one can have seizure. So it is likely with the alcohol also. If alcohol is stopped, then there may be chance of developing seizure in this case. And this is also because of increasing the expression of NMDA receptors. So CNS comes into hyperexcitable state after quitting the substance, and it may occur after 6 to 48 hours of abstinence. So primary medication for controlling the seizure is benzodiazepine. The first drug of choice is benzodiazepine like diazepam and lorazepam. And for long-term therapy, phenobarbital and gabapentin can be used for stable brain activity. So the protocol for controlling a seizure is similar to that any kind of seizure you will be controlling in your emergency department. So I think the first drug of choice to control the seizure is lorazepam itself. Delirium tremens. So delirium is a term used for clouding of consciousness, fluctuating level of consciousness, and certain set of symptoms are also there which constitutes a delirium. Delirium tremens means the delirium which occurs in severe alcohol withdrawal. Simply, the feature of delirium in any other delirium because of the other physical reason are more or less same, and this is because of the severe alcohol withdrawal and characterized by rapid onset of fluctuating course of uh, consciousness with disturbance in level of consciousness. Usually occurs after 48 to 72 hours, usual duration of 3 to 4 days, but might last for even longer for 8 days. So there is a downregulation of GABA aminobutyric acid and upregulation of NMDA receptor neurotransmitter, which can cause this delirium-like or delirious state. So delirium is always a disturbance of consciousness, and disturbance of consciousness is always delirium if the patient is not unconscious. The features are it is acute in onset, disorientation to time, place, and person is there. There will be fluctuating picture. In between the patient will looks fine, and in another few hours the patient found in the agitated or delirious state. Inattention is the one of the feature. Patient is not able to give attention. Reduced ability to focus, sustain, or shift attention is also there. Disorganized thinking, psychomotor changes may be hyperactive or hypoactive. Altered sleep-wake cycle or circadian reversal may be seen. The patient used to awake in the night and sleeping in the daytime. Perceptual disturbance like hallucinations are also common. The common hallucinations are Lilliputian hallucinations and hallucination and tactile hallucinations of small creature may be found in delirious state. Nocturnal worsening of symptoms is the feature of delirium when the stimulus is reduced because of the night time. The worsening may be there. Autonomic hyperactivity may also be there. So now coming to Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome may occur due to severe lack of thiamine because of the malnutrition. So Wernicke's encephalopathy is a sudden and severe acute brain disorder, and Korsakoff syndrome is a long-term memory disorder. So etiology of Wernicke's-Korsakoff syndrome is thiamine is the coenzyme which is required in the Krebs cycle and the pentose phosphate pathway, which functions in carbohydrate metabolism as coenzyme and in the decarboxylation of pyruvic acid and alpha ketoglutarate acid. When thymine is not there, the biochemical reaction does not occur as it has to be. Then pyruvate and alpha ketoglutarate is accumulated in neuron and blood and may damage the neuronal cells. When this is severe and if this cannot be reversed or is settled as a permanent condition, this can be said as alcohol induced dementia. The symptoms of Wernicke's encephalopathy can be remembered by GOA, GOA, global confusion, oculopathies, and ataxia. In Korsakoff syndrome, there is a severe memory loss, inability to form new memory if added upon to the symptoms of GOA. The Korsakoff syndrome is consequence of Wernicke's encephalopathy. The other symptoms are loss of coordination, confabulation, confusion, delirium, which is already set in before onset of Korsakoff syndrome, drowsiness, tachycardia, hypotension, hypothermia, eye issues like double vision, drooping eyelid, ptosis may also be found in WE syndrome. In Korsakoff syndrome, the symptoms include amnesia is the peculiar feature of Korsakoff syndrome in addition to uh, GOA symptoms. Behavioral changes like agitation, anger, confabulation. Confabulation means if the person is not able to uh, remember the things of a certain period of time, they try to fill that gap with new or fabricated memory. This is confabulation. Delirium, disorientation is there, fatigue, lethargy, hallucinations may be there, lack of focus, attention, and unsteady gait. Lab tests which are required, these two conditions should be treated aggressively in the ICU. So arterial blood gas as per the requirement, complete blood count, toxicology screening if there is a doubt of having substance history. Imaging can be required like CT scan, MRI, and electrocardiogram for cardiac changes. So what is the treatment when it is expected that the person may develop Korsakoff syndrome? The person is lean and thin, cachexic, or having poor nutrition, is dehydrated. So certain point can say the person can develop Korsakoff syndrome or Wernicke's encephalopathy. Then prophylactic thymine in doses of 200 to 300 milligram per day for 5 days, IV or oral can be given. The total is around 1000 to 1500. This is the prophylactic treatment. If the patient has developed already the syndrome, then corrective treatment is required, which means 500 milligram thymine to be infused at least 3 times a day for 5 days along with the injection multivitamin. Multivitamin because of the other uh, nutritional deficiency because of the alcohol use. In corrective treatment, one thing should be noted, intravenous dextrose should not be given uh, when these syndromes are developed, because if you provide it with the dextrose and the brain is not able to utilize the dextrose in absence of thymine, then there is a more accumulation of pyruvate and alpha ketogluteric acid. Isotonic saline is useful. Isotonic saline can be used, and dextrose should be safely administered once the patient has received the replacement thymine, if it is required or needed. In summary, withdrawal starts after 8 hours. Complication starts usually after 48 to 72 hours. Complication may prove fatal, must be treated in ICU aggressively. Benzodiazepines are the mainstay of the treatment. Higher doses are required in complication for longer period. Don't forget to give thiamine in appropriate doses. Don't give dextrose in thiamine depleted state. Now coming to the opioids withdrawal, you will understand the neurobiological basis of dependence and withdrawal. You can see in the picture, there is a neuronal cell wall, and on the top of it there is mu receptor, and Inside the cell there is a converting enzyme ATP which convert to cyclic AMP. So when the normal opioids are active, then this is the normal biochemical reaction. uh, Adequate amount of ATP is uh, and adequate amount of cyclic adenosine monophosphate are there, and which in turn triggers the release of norepinephrine. So the final resultant is the release of norepinephrine, noradrenaline, or same. What happens when opioid attached to the mu receptor, external opioid, the substance attached to the mu receptor, it reduces the availability of cyclic AMP because of the continuous blockage and continuous use of the opioid. And when this opioid dependence or occupancy of opioid to the mu receptor is prolonged, then ATP started generating itself in the more amount to compensate the amount of cyclic AMP which is produced naturally. In the last, when the person is tries to discontinue the substance, or in the abstinent state, in the initial phase, the more than the required ATP is there because of the substance abuse, and when mu receptor is freed up, then these excessive amount of ATP started producing more amount of cyclic AMP and leading to excessive release of norepinephrine. And the patient experiences the withdrawal symptoms like jitteriness, anxiety, muscle cramps, rhinorrhea, diarrhea, muscle pain, and all. So in pharmacology of opioid dependence, we have opioid agonist, partial agonist, opioid antagonist, and non-opioid drugs. Opioid agonists are used for uh, replacement therapy like morphine, dihydrocodone, oxycodone, hydrocodone, and fentanyl. These are the opioid agonists which may be used by the person for dependence. Partial agonists are buprenorphine, and tramadol is a more complex drug which is low potency mu agonist and partial agonist. Opioid antagonists, naltrexone and naloxone are there, and non-opioid drugs like alpha-2 adrenergic agonist is also available. We will see further how these drugs are used in withdrawal state. The withdrawal symptoms are pupillary dilation, diarrhea, rhinorrhea, sweating, lacrimation, insomnia, yawning, muscular and abdominal pain, restlessness, and craving. In addition, there may be autonomic excitability, which is seen as tachycardia, hypertension, piloerection, shivering, low mood, irritability, and anxiety. So, what are the molecules which are available for substitution therapy for treatment of opioid withdrawals are methadone, buprenorphine, tramadol, and tapentadol. Other molecules are also available, but in our practice here we used to use uh, buprenorphine, tramadol, and tapentadol, which is easily available. So the mechanism is, you can see that the blue part on the cell wall is mu receptor. Uh, when the patient is dependent on substance, these receptors are occupied with those substance, and if it is if the person is try to quit it without the help of the other drug, it will lead to severe withdrawal. So to reduce or curb the severe withdrawal, this can be replaced by the drugs which are buprenorphine, methadone, and tramadol. So mu receptor is occupied by these drugs, and alpha-2 adrenergic receptor take care of the norepinephrine release in autonomic symptoms. The drugs which can be used in alpha-2 adrenergic receptors are clonidine, lofexidine, and tizanidine. What are the doses to detoxify the opioid dependence? If you are using buprenorphine, begin when the withdrawal symptoms emerge. So day 1, 2 to 4 milligram every hour for 4 hours. The total of 8 to 12 milligram of dose is required for day 1. On day 2, 60 milligram in divided doses, like 8 milligram twice daily. And from day 3 to 9, decrease by 2 to 4 milligram per day as tolerated. Add clonidine 0.5 milligram every 4 to 6 hours for breakthrough symptoms of autonomic hyperactivity. While giving the clonidine to reduce the hyperactivity, autonomic hyperactivity, one should keep in mind that clonidine is also a central antihypertensive. To take care of the hypertension of the patient, it should be monitored with this drug, and basically the symptoms are peak at second to third day, and by third day you may started decreasing those as per the guidelines. Methadone, to begin with, on day 1 with 10 milligram, increase by 10 milligram every 6 to 8 hours for maximum dose of 40. And then for second day there are two options. Day in option 1, day 2 to 4 decrease by 10 milligram each day, and day 5 to 8 decrease by 2 milligram each day. Option 2 is day 2 to 8 decrease by 5 milligram each day. So basically one have to gradually decrease the doses so that the body can slowly adjust to the previous state of uh, biochemical homeostasis. Clonidine is, if required, then on day 1 it may be given in the 0.1 to 0.2 milligram every 4 to 6 hours with maximum dose of 1.2 milligram. Day 2 onward taper by 1.1 to 0.2 milligram per day. Lofexidine, day 1 0.5 to 0.7 milligram every 6 hours. On day 2 and onwards, decrease each dose by the zero point 0.2 milligram every 1 to 2 days. Now, after controlling the mu receptor and the alpha adrenergic receptors, some other drugs are may also be required, are ancillary drugs, like for anxiety, clonazepam may be used. For muscle cramps, ibuprofen uh, can be used. For nausea, vomiting, and diarrhea, ondansetron, prochlorperazine can be used for nausea, vomiting, and diarrhea. For sleep, additional trazodone and zolpidem may be required. So it is the symptom-based approach, and treatment is a process in the case of withdrawal of any drug. Now coming to the cannabis use disorder, which is also common substance use disorder in this geographical area. So we all know that exogenous cannabis, which has tetrahydrocannabinol, acts on the endogenous cannabinoid system in the brain by binding the receptor CV1 and CV2. So CV1 receptor are located primarily in presynaptic neuron of the CNS and are responsible for acute psychological and cardiovascular effect. And CV2 receptor is located in the periphery and modulate immune function and inflammatory responses. So CV1 is particularly for the CNS. In withdrawal syndrome of cannabis, the symptoms are anxiety, irritability, depressed mood, restlessness, disturbed sleep, GI symptoms, and decreased appetite. And most symptoms begin during the first week of abstinence and resolve after few weeks. The drugs which can be helpful in cannabis withdrawal, there is no particular antidote for this, uh, but the drugs which are studied and shown the results and which will be discussed here is the bupropion and divalproex worsens the withdrawal. It should be avoided. Fluoxetine reduce the cannabis use, should be used for relapse prevention.
Nefazodone improves anxiety during the withdrawal. Lofexidine with tetrahydrocannabinol reduces the withdrawal symptoms. Cannabis agents like oral THC, oral tetrahydrocannabinol capsules reduces the withdrawal. Dronabinol has mixed result, and cannabis antagonist is known as rimonabant attenuated the effect of cannabis in later maintenance state. So rimonabant can be used in relapse prevention as blocking agent. In summary, symptomatic treatment is the mainstay. Rimonabant may prove useful. Withdrawal lasts for days to weeks. Various drugs like oral THC, lofexidine, rimonabant can be used to attenuate withdrawal. For long-term abstinence, fluoxetine and rimonabant can be used for relapse prevention. Now, sedative, hypnotic, and anxiolytics means benzodiazepines. So we have discussed the tapering of benzodiazepine in alcohol withdrawal part in this session. So same protocol is used for sedative, hypnotic, and anxiolytic. You have to calculate the equivalent dose as per the diazepam and to make a protocol to gradually taper down the doses of substituted benzodiazepine. Withdrawal of stimulants. So there are no reliable, effective, specific pharmacological treatment is available for stimulants. Supportive care is the mainstay. Unlike withdrawal syndrome described for alcohol, benzodiazepine, barbiturate, stimulant withdrawal is generally milder, self-limited, and not typically associated with delirium or other medical complications. So supportive and conservative care is mainstay. For cocaine, to date, there is no approved medication to treat cocaine use disorder is available. Trials of direct dopamine agonist, which increases presynaptic dopamine release, has also not shown benefit in these patients. Dextroamphetamine has a mixed result. The atypical psychostimulants modafinil has shown little benefit, and that cannot be generalized. A sustained release formulation of methylphenidate did show benefit in one study. Opioid antagonists like naltrexone and typical and atypical antipsychotics and the D1 receptor antagonist ecopipam have all been investigated and none have shown clear evidence of benefit against the placebo. Disulfiram also appears to have a more direct pharmacological effect on the metabolism of dopamine and cocaine itself and found helpful. Baclofen, tiagabine, modafinil, which likely affects the GABA and glutamate neurotransmissions, have failed to show any benefit. So, the symptoms of caffeine detoxification of caffeine, the symptoms of caffeine withdrawal typically resolve with the ingestion of dose of caffeine. The person with provisional diagnosis of caffeine withdrawal more than 2 weeks should be carefully rehabilitated for another diagnosis. Headache may be taken care of by aspirin and other analgesics. If caffeine withdrawal occurs because a person is attempting to abruptly stop the caffeine use, advise the patient to taper caffeine consumption over the period of time. So no specific antidote is available for caffeine also. So gradual reduction of caffeine consumption can be done in the control environment also and can be advised to the patient on OPD basis. Now hallucinogens. What are hallucinogens? The molecule like LSD, PCP, ketamine, psilocybin, mescaline are the hallucinogens. In withdrawal symptoms, there is no recognized set of symptoms. There is no recognized syndrome of withdrawal of hallucinogens in the humans. Supportive treatment again is the mainstay for hallucinogen withdrawal. The efficacy of psychosocial treatment afterwards the detoxification that have empirical support for the treatment of other substance use disorder is unknown in the case of hallucinogen use disorders. So there are scarce data for these. For volatile substance detoxification, case studies show that in reducing craving, aripiprazole and lamotrigine are useful. For withdrawal symptoms, baclofen is useful. Neuropsychiatric symptoms can be taken care of by carbamazepine, haloperidol, and risperidone. Behavioral symptoms such as increased locomotor activity can be controlled by vigabatrin. So again, the treatment is supportive. No particular antidote is available for volatile substance. In the last, there is nicotine withdrawal. In nicotine withdrawal, although won't come in the emergency for their withdrawal symptoms, but one can have idea how to detoxify the person who is consuming nicotine. So basically, it's a OPD procedure in which what is required is to set a quit date. The patient has to set a quit date, and on that date, he has to stop the substance abruptly. And some patient seizes it abruptly, but some are required to quit the substance in a gradual manner. So brief advice should be focused uh, on the need of medication, group therapy, weight gain concerns, high risk situations, making cigarette unavailable, and so forth should be discussed with the patient in the detoxification of or de-addiction of nicotine dependence. Follow-up should be with the shorter period of time like 2 to 3 days because relapse is often rapid and quick in the nicotine withdrawal. The available modalities which are used for replacement for nicotine are nicotine gum, nicotine patches, microtabs, lozenges, inhalers, and nasal sprays. In our setup, the gum, lozenges, and patches are widely available or and can be used. Non-nicotine medication which are useful in tobacco dependence are bupropion is said to reduce the craving and it can be given for 6 to 12 weeks or more. The doses are 150 to 300 milligram. Again, the clonidine reduces the sympathetic activity in the locus coeruleus. Nicotine vaccines are there in under development. Uh, currently it is not available, but it's a good hope for the nicotine dependent patient in the future. When it is available, this will be a good choice. Another drug for nicotine dependence is varenicline. Varenicline is cholinomimetic drug, or you can say it is a blocking agent. So for day 1 to 3, 0.5 milligram orally once a day is required, and from day 4 to 7, 0.5 milligram orally 2 times a day, and by the 8th day 1 milligram orally 2 times a day. The duration of therapy is 12 weeks. So it's a blocking agent. It is required in the period of relapse prevention when there is propensity to slip to the substance. So one can give this. The role of this varenicline is when the varenicline is in the body, it will acquire the cholinomimetic receptors, the nicotinic receptors, and if the patient tries to smoke or chew the tobacco, he will not get that effect what he was having before the uh, detoxification. So thank you. So we had discussed about the alcohol withdrawal, opioid withdrawal, cannabis withdrawal, other substance like volatile substance, hallucinogens, caffeine and nicotine withdrawal symptoms and how they can be treated. So hopefully this would be a good and informative lecture for you, and you are in the position to deal with this patient efficiently. No? So thanks to you. So good morning to all. So today we will learn about the fatal side effects of the psychotropics and its management. So you you may also understand what are the drugs are being used in the psychiatry and what side effects can they have which may be proved fatal. So we will go through that, and the other conditions which may prove fatal in terms of psychiatric emergency. So to start with, we will have an introduction, the risk factors, side effects related to antipsychotics, mood stabilizer, antidepressants, anxiolytic sedatives, and summary. So as you know that psychotropic medications often provide relief and stability to millions of mentally ill patients, and further they are not without the risk. Side effects are there, and some serious side effects may be there which may prove fatal to the patient. So you must be aware about the specific drug commonly associated with the dangerous outcomes and key warning signs and symptoms and management strategies. First, we will talk about the risk factors. Risk factors may be pre-existing medical conditions like cardiovascular diseases. Many psychotropics can cause arrhythmias, prolongation of QT interval, and sudden cardiac death. So, pre-existing cardiovascular disease may cause an additive effect to the drugs. Liver or kidney impairment can lead to toxic buildup of the blood levels of the drug and increasing the risk of overdose and fatal side effects. Respiratory disorders like COPD are at higher risk, especially with the sedative, opioids, and certain antipsychotics, which may depress the respiration. Another risk factor is age. Elderly patients and children and adolescents are uh, differently metabolize the drug. The pharmacokinetics and dynamics are the different. Polypharmacy may be one of the risk factor because of the increased drug to drug interaction and additive effect of substance like alcohol, opioid, or benzodiazepine may have a detrimental effect with the combination of other psychotropics. Higher doses and rapid dose changes of the drug are also a risk factor to development of for the development of life-threatening conditions. Metabolic factors like genetic variations in the metabolism of the drug, like slow metabolizer or fast metabolizer, may uh, have some different kind of adverse effect of the drug. Obesity also pose a may pose a danger, and it can alter the pharmacokinetics and potentially leading to a drug accumulation and side effects. Non-compliance and abrupt discontinuation may also result in sudden withdrawal syndrome, and non-compliance itself can lead to therapeutic instability and may increase the risk of relapse, overdose, and adverse reactions. Substance abuse may combining psychotropics medication with substance of abuse increase the risk of overdose, respiratory depression, or cardiovascular events. Psychiatric conditions, high risk behavior like suicidal tendencies and tendency of hostility, agitation, and aggression may also lead to uh, syndrome like neuroleptic malignant syndromes. Pregnancy and lactation is also can have a teratogenic effect of drugs like valproic acid. Perinatal risk of drugs like benzodiazepine can lead to withdrawal symptoms and respiratory depression in newborns. There are black box warnings for the antipsychotics, which should be kept into the mind while treating with the antipsychotic drugs. Poor monitoring also a risk factor to development of lethal side effects. So now we will talk about the antipsychotics. Antipsychotics can cause cardiac changes, diabetic ketoacidosis, pneumonia, agranulocytosis, thromboembolism, and myocarditis. So what are the factors and what are the mechanisms we will see. So regarding the antipsychotic, with dopaminergic D2 antagonism at mesolimbic area cause antipsychotic effect for the illness itself, and D2 receptor at nigrostriatal pathway can lead to extrapyramidal side effects, and binding at D2 receptor at tuberoinfundibular pathway may lead to hyperprolactinemia, Muscarinic M1 antagonist may lead to blurring of vision, constipation, urinary retention, sedation, memory impairment, and sinus tachycardia. At H1 receptor, it may produce sedation and weight gain. At alpha 1 adrenergic receptor action, dizziness, postural hypotension, bradycardia, and sedation may be seen with the antipsychotics. The risk of hypothermia is with the action at 5-HT2 receptor, and prolongation of QT interval is due to inhibiting cardiac potassium ion channels. Now, medication-induced movement disorders uh, like neurolap malignant syndrome is a condition which may lead to fatality, and it is characterized by generalized lead pipe muscle rigidity and elevated temperature, altered consciousness, and autonomic system dysregulation. The symptoms may be diaphoresis, tachycardia, elevated or labile blood pressure, urinary incontinence, pallor, and cyalorrhea. Other symptoms will be dysphagia, dysarthria, trismus, myoclonus, echinacea, tremor, and delirium. In lab finding, you will have leukocytosis, metabolic acidosis, evidence of muscle injury like elevated creatinine kinase and dysfunctional kidney performance and liver enzyme elevation. So basically, in the core symptoms, you will have lead pipe muscle rigidity all over the body and extreme elevation of temperature, high grade, maybe more than 103 and 4, and the altered consciousness, like delirious-like condition and autonomic system dysregulation. So with this condition, one have to rule out thyrotoxicosis, malignant hyperthermia, Parkinsonian hyperthermia, serotonin syndrome by the SSRIs and antidepressants, malignant catatonia. These conditions should be ruled out to diagnose neurolap malignant syndrome. This is the pictorial presentation of NMS. In addition, you may found increased vowel sounds, agitation, diaphoresis, tachycardia, autonomic instability, tremor, clonus, and hyperreflexia. The management and intervention is supportive. Uh, Intervention is IV hydration, temperature control, and in more severe cases, ventilator support and dialysis may be required. And oxygenation, cooling blanket, ice pack, ice water enema, and antipyretic are required to control the temperature. A rapid onset or worsening of symptom requires transfer to a medical intensive care unit. Re-exposure to antipsychotic can be considered after full resolution of the episode. So at this stage, do not bother about the psychiatric illness. So first, one have to save the life. So the person should be treated aggressively in medical setup. The drugs which are useful in neurolap malignant syndrome are amantadine in 200 to 400 milligram per day by mouth in divided doses. Bromocriptine 2.5 milligram twice a day or 3 times a day by mouth may increase to a total of 45 milligram per day. Levodopa and carbidopa can also be used to release the muscular rigidity. Dantrolene is also helpful, 1 milligram per kg body weight per day, parenterally for 8 days. Benzodiazepine may also be beneficial uh, as a test dose. 1 to 2 milligram intramuscular can be given as test dose. If effective, switch to oral route. Consider if catatonic symptoms are present. So this is also a subtle muscle relaxant can be used in NMS. Electroconvulsive therapy is also useful, either unilateral or bilateral. Response may occur as few as uh, 3 sets of ECT sessions are given. In another medication-induced movement disorder, the condition is acute dystonia. You may be uh, aware about this. The symptoms include abnormal positioning of head and neck, like torticollis, retrocollis, spasm of jaw muscle, trismus, impaired swallowing, speaking and breathing, slurred speech, trunk protrusion or dysfunction. Deviated eye in any direction, which is known as oculogyric crisis, and abnormal positioning of limbs and trunk of tonus. So rigidity is here also, but the condition is acute dystonia, which should be differentiated from neural malignant syndrome. In the management, parenteral IM or IV benztropine 1 to 2 milligram or diphenhydramine 50 milligram typically produce rapid relief. The relief occurs within seconds and minutes. So diphenhydramine, you must be aware about the injection Finargan, which can be used IM or IV to relieve the symptoms. The condition may prove fatal when there is laryngeal dystonia, can compromise breathing. Immediate recognition and treatment is essential for this condition. Antipsychotic related QTC prolongation, we all know that the cardiac potassium channel is hampered by the effect of antipsychotic and may lead to ventricular arrhythmia known as torsades de pointes. And this effect may be probably dose related, and QTC interval, uh, the cardiac QT interval is a useful but imprecise indicator of risk of torsades de pointes of increased cardiac mortality. So the drug which has high effect on the QT interval are any IV antipsychotic may produce that effect, and in oral form, pimozide, haloperidol, methadone, and sertindol can cause uh, prolongation of QT more than of 20 millisecond. Moderate effect can be seen by chlorpromazine, iloperidone, melprone, quetiapine, ziprasidone, zotapine, and tricyclic antidepressants as well. Low effect can be seen with all these drugs like amisulpride, clozapine, flupentixol, olanzapine, and risperidone. Other reported antipsychotic induced changes include atrial fibrillation, giant P waves, T wave changes, and heart block. This should also be kept in the mind while you receive such a patient who is on antipsychotic. The drugs which has no effect on QT interval is worthy to note. The safer drug in relation to cardiac activity, the one is aripiprazole, the paliperidone, SSRIs, reboxetine, nefazodone, mirtazapine, MAO inhibitors, carbamazepine, gabapentin, lamotrigine, valproate, and benzodiazepines. Physiological risk factor for QTC prolongation and arrhythmia, maybe long QT syndrome, bradycardia, ischemic heart disease, having history of previous ischemic heart disease, myocarditis, myocardial infarction, left ventricular hypertrophy. Metabolic risk may be hypokalemia, hypomagnesemia, hypocalcemia. Other risk factors may be extreme physical exertion, uh, the acute agitation or excitement because of the psychiatric illness itself, stress or shock, anorexia nervosa, extremes of age like children and elderly may are more susceptible to QT changes. Female gender is also more susceptible. The management should be to weigh the risk benefit of the treatment and the ECG changes. ECG monitoring is required uh, in hospital setting and recommended before initiation and dose adjustment of the QTC prolonging agents, which we had discussed in earlier slides, and follow-up ECG 8 to 12 thereafter may be done. Electrolyte imbalances may also be taken into account, like hypocalcemia, kalemia, and magnesemia can increase the risk of QT prolongation. The management, when the QTC is less than 450 millisecond or less than 470 millisecond in the woman, no action is required unless abnormal T wave morphology is seen, and this should be considered referring to the cardiologist if in the doubt. If it is more than 440 and 470 in men and women respectively, but it is less than 500 millisecond, consider reducing the dose. As we have discussed that the QTC prolongation is dose dependent, consider reducing the dose or switching to the drug of the lower effect on the QTC. Repeat ECG and consider referral to the cardiologist. If it is more than 500 millisecond, stop suspected causative agent and switch the drug to the lower effect and refer to the cardiologist immediately. For abnormal T-wave morphology, review treatment, consider reducing dose, switch to the drug of lower effect, refer to cardiologist immediately. Now, diabetic ketoacidosis. So, we all know that the uh, antipsychotics can lead to metabolic syndrome, and the metabolic syndrome, uh, the one part of the metabolic syndrome is uh, insulin resistance and obesity, which may lead to diabetic ketoacidosis. The high risk drugs are clozapine and olanzapine. Moderate risk are with the quetiapine, risperidone, phenothiazines. Low risk with the high potency first generation antipsychotics like haloperidol, and minimal risk is with the aripiprazole, amisulpride, acinapine, lurasidone, and ziprasidone. So minimal risk is with these the group of these drugs are almost of third generation antipsychotics. So third generation antipsychotics have the minimal effect. This is a secondary effect of metabolic syndrome which may lead to diabetic ketoacidosis. In the management, correction of fluid loss with the IV fluids, correction of hyperglycemia with insulin, correction of electrolyte disturbances, particularly the hypokalemia, and correction of acid-base balance, treatment of concurrent infection if the infection is present. And it is essential to maintain extreme vigilance for any concomitant process such as infection, cerebrovascular accident, myocardial infarction, sepsis, deep venous thrombosis. Drug-induced SIADH, syndrome of inappropriate secretion of antidiuretic hormone. This may be as high as 11% in acutely ill psychiatric patient, and hyponatremia present as delirious-like picture with the confusion, nausea, headache, and lethargy. As the plasma sodium falls, these symptoms become increasingly severe and may develop result into the seizures, and coma can be the consequence. So in the causes, the high risk drugs are phenothiazine, haloperidol, chemozide, risperidone, quetiapine, olanzapine, aripiprazole, and clozapine. Desmopressin use can also result in hyponatremia when used in conjunction with the clozapine. Severe hyperlipidemia or hyperglycemia lead to secondary increase in the plasma volume and may lead to pseudo hyponatremia. Management is in mild fluid restriction with careful monitoring of serum sodium can be done. Refer to a specialist medical care if sodium is less than 125 millimole per liter, and that should be treated in emergency units or in the intensive care units. Switching to a different antipsychotic may be one of the step, and there are sufficient data available to guide the choice. Consider dameclocycline in such cases. Lithium may be effective, but is potentially a toxic drug. Can be used very judiciously. Remember that hyponatremia predisposes to lithium toxicity as well. Pneumonia. The mechanism by which antipsychotic increase the risk of pneumonia is not known. The possible mechanism may include sedation, dystonia, dyskinesias, dry mouth causing poor bolus transport, leading to aspiration and so increasing the risk of aspiration, general poor physical health, and perhaps some ill-defined effect on the immune response. So, inactivity may be the cause of pneumonia in patients who are on the antipsychotics. So, pneumonia should be managed as per protocol. You are already must be doing the management of acute pneumonia. So, protocol should be followed for these cases also. So this is the drug clozapine, which has a particular indication for schizophrenia, and it is considered to be a drug which has effect on resistant schizophrenia, but the drug has also certain specific side effects which can be taken into account. The one is agranulocytosis. It is a life-threatening adverse effect and it may be found in 0.8% of population. The mechanism is not clear and the target cell may be myeloid precursor or mature neutrophils. So in agranulocytosis, if the TLC counts fall very rapidly uh, by more than 30% or below the 3000 in total, the this condition can be considered of and to be act accordingly. Thromboembolism, the risk of thromboembolism is estimated to be 1 in 2000 and 1 in 6000 patient treated. Thromboembolism may be related to clozapin's observed effect on antiphospholipid antibodies and platelet aggregation. So it seems most likely to occur in the first 3 months of the treatment. So both these conditions should be considered if the patient is on clozapine. The another effect of clozapine is myocarditis. And myocarditis is a side effect of adverse effect of clozapine and should be taken into account if the person is on the clozapine. And the symptoms include hypotension, tachycardia, fever, flu-like symptoms, fatigue, dyspnea, and chest pain. Signs include ECG changes such as ST depression, enlarged heart on radiography or echo, and eosinophilia. So these are the signs for myocarditis when the patient is on clozapine. The reason may be rapid dose increment of the drug, concurrent use of sodium valproate with the clozapine, and older age are the risk factors. Further, cardiomyopathy can also be the adverse effect of clozapine, and immediate cessation of clozapine is required and referral to the emergency unit and or intensive care unit is required. The symptoms may be palpitations, chest pain, syncope, sweating, decreased exercise capacity, breathing difficulty. You all know about the symptoms of cardiomyopathy. Younger patient may have an increased risk of sudden death. Lithium toxicity. So lithium is a drug which is used for mood stabilizing purpose. So mild toxicity can have symptoms like fine tremors of limb, cogwheel rigidity, GI disturbances, to the severe toxicity level, which may be present with coarse tremors of limb, delirium, stupor, clonus, seizure, and again QTC interval prolongation, renal failure, respiratory complication, and which may lead to coma and death. Management of lithium toxicity. You must have gone through the previous lecture on exclusively on lithium and you must be aware of the management. The plan of management is to shift the patient to emergency room and discontinue the lithium immediately, do the complete physical examination and MSC. The lab value required for lithium in the blood, serum electrolyte, renal function test, ECG. For acute ingestion, gastric lavage should be done if it is taken voluntarily or accidentally in the excessive amount. Vigorous hydration and maintenance of electrolyte is essential. Hydration uh, and any patient with lithium greater than 4 milliequivalent per liter may require hemodialysis. Repeat dialysis may also be required until signs and symptoms are reduced. With sodium valproate, one can have fulminant hepatic failure as a serious adverse effect, pancreatitis, hyperammonemic encephalopathy, agranulocytosis. Stevenson-Johnson syndrome may occur with certain drugs which are used in case of psychiatric illness, and this is a form of toxic epidermal necrolysis. It is a life-threatening skin condition in which the cell death causes the epidermis to separate from the dermis. The syndrome is thought to be hypersensitivity complex that affects the skin and the mucous membrane. So you will find the lesion mostly in the skin and in the mucus. You can check for the oral cavity for the patient and other skin lesions. This condition begins with fever and sore throat and fatigue, which is commonly misdiagnosed and thereafter treated with antibiotics. Ulcers and other lesions begin to appear in mucous membrane, almost always in the mouth and lips, but also in the genital and anal regions. Conjunctivitis of eyes occur in about 30% of children who develop SJS. A rash of round lesion about an inch across the face, trunk, arms, legs, soles of the feet, but usually not on the scalp. So check for these area and the oral cavity to be sure of the SJS. So it has motility rate of around 5%. The motility for toxic epidermal necrolysis is around 30 to 40%. Now coming to the antidepressant related life threatening side effects. Tricyclic antidepressants have established arrhythmogenic activity which arises as a result of potent blockade of cardiac sodium channels and variable activity at potassium channels. So TCS can also lead to cardiac arrhythmias, and the ECG changes include PR, QRS and QT prolongation and Brugada syndrome. ECG monitoring is more meaningful, are associated with arrhythmia and sudden cardiac death. The fatal toxicity index figure suggests high toxicity for tricyclic drugs, especially dosolopin is more uh, for this fatal toxicity index. Medium toxicity for venlafaxine and moclobemide is seen, and low toxicity is seen with the SSRI, betazapine and reboxetine in terms of asthmogenic activities. So the safer drugs are SSRI, mirtazapine and reboxetine. Antidepressants can also induce bleeding. So what is the mechanism? Normally serotonin is released from the platelets in response to vascular injury and promotes vasoconstriction and morphological changes in platelet that lead to aggregation and blockade of the bleeding site. So what SSRIs does is they inhibit the SERT and responsible for uptake of serotonin in platelet, and SSRI will deplete the platelet serotonin by inhibiting the reuptake of serotonin into the cell and reducing ability to form clots and subsequent increase in the risk of bleeding. The excess risk of bleeding is not confirmed to upper GI bleed. The risk of lower GI bleed may also be increased, and an increased risk for uterine bleeding has also been reported. SSRI should be used cautiously in patients with cirrhosis and other risk factor for internal bleeding. So this condition you should also be aware of. Further, the co-prescription of low-dose aspirin at least doubles the risk of GI bleeding associated with SSRI. So keep in mind uh, for this combination. SSRI increase the risk of GI cerebral perioperative bleeding and should be taken account to when the person uh, is planning for surgery or undergoing any kind of surgery. Try to avoid SSRI in patients receiving non-steroidal anti-inflammatory drugs, aspirin or anticoagulants, or with history of cerebral and GI bleeds. If SSRI use cannot be avoided, monitor closely and prescribe gastroprotective proton pump inhibitor, uh, which may be somewhat useful to reduce the bleeding. Serotonin syndrome is also a serious side effect of drugs which are acting upon inhibiting the reuptake of serotonin in the brain cells. The clinical triad for serotonin syndrome is change in mental state, like delirium like state, autonomic hyperactivity is there, neuromuscular abnormalities also be there in serotonin syndrome. So this is the pictorial manifestation. The patient may present with diaphoresis, agitation, hyperreflexia, tremor, clonus, autonomic instability. Hyperreflexia and tremors is more pronounced in the serotonin syndrome, and there is a condition called as jitteriness. Jitteriness will be found in these patients, and in comparison to NMS, neural malignant syndrome, where rigidity will be profound presentation. Management is removal of precipitating agent, the drug which is causing it, provision of supportive care, control of agitation can be done by administration of 5-HT2A antagonist, control of autonomic instability should be done by the conservative management, control of hyperthermia by various means. Many cases of serotonin syndrome typically resolve in 24 hours after the initiation of therapy and discontinuation of serotonergic drugs. And this should also be differentiated from lithium toxicity syndrome. In management, for milder cases can usually be managed with supportive care, removal of the precipitating drug, and treatment with benzodiazepines. Medically ill patients should have all cardiorespiratory and thermal abnormalities are aggressively corrected and may benefit from the administration of 5-HT2A antagonists. Hyperthermic patients are severely ill should receive the above therapies as well as immediate sedation, neuromuscular paralysis, and orotracheal intubation. Control of agitation with benzodiazepine is essential in management of serotonin syndrome, regardless of its severity. Physical restraints are ill-advised in such condition or any kind of uh, serious condition which were discussed before, and this may contribute to mortality by enforcing isometric muscle contraction that are associated with severe lactic acidosis and hyperthermia and may lead to exhaustion also. Hypertension and tachycardia should be treated with short-acting agents such as nitroprusside and esmolol. In severely ill patient with hyperthermia, immediate paralysis should be induced with non-depolarizing agents such as V-curonium followed by orotracheal intubation. Avoid succinylcholine because of the risk of arrhythmia from hyperkalemia associated with the rhabdomyolysis. There is no role for antipyretic agent in management of serotonin syndrome. The increase in body temperature is due to muscular activity and not an alteration in the hypothalamic temperature set point. So antipyretics should be avoided and should not be used in case of serotonin syndrome. So these were the few conditions which one can came across through while the patient is on psychotropics like antipsychotics, mood stabilizers like sodium valproate, lithium, and antidepressants should be kept in mind when the patient arrive with such a condition who is on the psychotropic medication for some or other illness. So thanks to all for patient listening.
Good afternoon. So we'll start today's topic, that is lithium toxicity. Lithium toxicity is something which you will see in emergency department and may get confused with other similar conditions which can occur in other medical illnesses. So just a brief introduction about lithium. We majorly use lithium in a carbonate form for a mood stabilizer. It is used for the treatment of bipolar disorder, particularly for managing mania and preventing recurrence of mood episodes. There are other indications as well, which we'll see in the later slides. So the exact mechanism of lithium is not really understood, but there are still many neurotransmitter pathway and intracellular signaling which has been shown associated with mechanism of action. So in second messenger system, lithium inhibits enzymes like inositol monophosphatase, which affects the phosphodiol inositol cycle and regulates signal transduction in neurons. Next, there is also a neuroprotective effect of lithium is being seen, wherein it affects this glycogen synthesis kinase, which is involved in neuroplasticity and cell survival. Similarly, BDNF factor ka bhi association has been seen, which is showed promotes neuronal growth, survival, and synaptic plasticity. There are other theories which says ki serotonin, dopamine action is also being affected by lithium. Talking about pharmacokinetic, it is quickly absorbed and reaches the peak serum level within 1 to 1.5 hours for standard form, and if you are using an ER or extended release form, 4 to 4.5 hours. Mainly excreted by kidney, and there is some loss which can be seen in sweat and feces. It can also be transferred from breast milk as well. The elimination half-life is 18 to 24 hours. Next thing is lithium toxicity is what? It occurs when serum levels exceeds the therapeutic range due to overdose, drug interaction, or impaired renal clearance. And it is an emergency situation which requires immediate medical attention due to its life-threatening potential. So what are the indication wherein we give lithium? Bipolar affective disorder, major depressive disorder, schizoaffective, schizophrenia, in aggression. It has also been shown to be effective in suicide prevention, agranulocytosis, or cluster headaches. So moving on to what are the recommended serum lithium concentration. When we talk about acute treatment during the acute manic episode, the target serum concentration is 0.8 to 1 millimole per liter. For maintenance therapy, target serum is 0.6 to 0.8, and for augmentation in unipolar depression, we also, as we have seen in indication part, in major depression also lithium can be given. Target concentration is again 0.6 to 0.8 millimole per liter. Now, when does the toxicity level is seen? When the serum lithium level is more than 1.5 millimole per liter. Mild is 1.5 to 2 milliequivalent per liter, moderate is 2 to 2.5, and severe is more than 2.5. So there are certain clinical guidelines which you should keep in mind when you're starting the patient on lithium. A baseline blood investigation including renal profile, thyroid and cardiac function test should be done. ECG should be done, and along with baseline weight and BMI monitoring is also advised. Etiology and risk factor for lithium toxicity. So what are the causes and other risk factor which can give rise to lithium toxicity? First of all, dehydration like diarrhea, vomiting, excessive sweating, fever or inadequate fluid intake. It can raise the serum lithium level. Next, as we know, lithium is cleared from the kidney. So renal impairment like CKD, AKD, age-related decline in renal function can also result in increase in serum lithium level. Again, hyponatremia due to excessive sweating or poor dietary intake or the use of diuretics is also one of the factor which can cause lithium toxicity. As the age advances, the kidney functions are said to be deteriorated, so the multiple drug interaction can be seen in this case as well. In certain cases of gastroenteritis, severe infection or other condition where significant fluid loss is there or any renal impairment occurs, there also the serum lithium level can rise. Rapid dose titration, please keep it in mind. Lithium without appropriate monitoring or including the daily, exceeding the recommended dose can cause lithium toxicity. Again, there are certain drugs which can cause interaction with lithium and raise its serum lithium level like NSAIDs, in diuretics, thiazide diuretics, ACE inhibitors, ARBs, SSRIs and certain antibiotics like metronidazoles are also found to be notorious in increasing the serum lithium level. So if we talk about clinical presentation before the lithium toxicity, there are certain side effects which are dose related for lithium which can be managed symptomatically as well. So like diarrhea, abdominal discomfort, nausea, tremor. In intermediate side effect, you can see again it might lead to insipidus, diabetes insipidus, ataxia. Again, diarrhea and nausea can be seen in both the cases. And there are certain dermatological side effects like acne and alopecia has also been seen associated with renal toxin, lithium adverse effect. So when we move on to toxicity, when there is mild to moderate lithium toxicity, that is when the serum lithium level is 1.5 to 2 milliequivalent per liter. In GI side effect, you might see vomiting, abdominal pain, anorexia, diarrhea and nausea. Whereas in neurological side effect, ataxia, coarse tremor, confusion, drowsiness, muscle weakness and slurred speech can be seen. When moving on to moderate to severe, that is lithium level is 2 to 2.5 milliequivalent per liter. You can have persistent nausea and vomiting, whereas a neurological side effect, muscle twitching, clonic movement of the limbs, seizure, disorientation, coma can occur. Arrhythmias and conduction abnormalities are also seen. That is why baseline ECG is always advised when we start lithium. And in severe cases wherein it is more than 2.5 milliequivalent, generalized convulsion, oliguria, renal failure, coma and death ultimately. So these are just a table. This is just a table to show the major side effects, sorry, major ill effects of lithium toxicity. So how will you diagnose if the patient has lithium toxicity or not? Other than the clinical presentation, you will correlate it with serum lithium level. Serum lithium level is main indicator for diagnosis. Additional electrolyte like sodium and potassium disbalance, thyroid function test, blood urea and creatinine, ECG to detect arrhythmias, and urine analysis for kidney function. Now the differential diagnosis, there might be certain cases which might look like lithium toxicity, like alcohol intoxication, wherein slurred speech, dizziness can be seen, drug overdose, especially benzodiazepine and opioids, electrolyte imbalance, especially hyponatremia, uremia, renal failure, and certain neurological conditions like stroke and encephalopathy can look like or manifest like lithium toxicity. So management part, you will discontinue the medication immediately. Please keep in mind whenever the patient is coming to emergency, ABC is your rule. Check for airway, breathing and circulation of the patient. Give symptomatic treatment whenever required, oxygen inhalation, IV fluids. Gastric lavage, if overdose is recent, you can repeat it as well. Obtain an urgent serum lithium level to confirm toxicity. Administer IV saline. Avoid hypotonic solutions like D5, which can exacerbate hyponatremia. Correct the electrolyte balance, especially if hyponatremia is seen. Hemodialysis may be required if the intoxication level are higher, that is more than 3 millimole per liter. It might be seen that lithium level can increase after initial dialysis due to rebound effect of lithium. So multiple sessions of dialysis can be required. Clinical symptom may improve slower than serum levels due to slow CNS clearance. Okay. So to conclude, lithium toxicity is a medical emergency requiring prompt diagnosis and treatment. Ensure that patients are aware of symptoms and drug interaction. Whenever you're prescribing lithium, tell people about these are the following side effects, this can happen, and tell them about certain drug interaction. Inquire their medical history, their psychiatric history as well. Baseline lithium workup, as I already told you. Serum lithium concentration is the best indicator. In fact, when you start lithium, after 5 to 7 days, serum lithium monitoring should be done. What is the concentration of the drug? Whenever you change the drug, whether you increase or decrease the drug, again the serum lithium monitoring after 5 to 7 days of changing the dosage of the drug should be done. And it requires immediate medical attention. These are the references, and thank you. Good afternoon. Let us move towards the topic which is approach to panic attack in emergency. So emergency में panic attack patients you are going to see more often, and the symptomatology may mimic many of the physical or medical conditions. So it is very important for you to understand and differentiate them as soon as possible. So we'll be covering it under the following headings. So introduction, what do you mean by panic attack? A panic attack is defined as a sudden surge of intense fear or discomfort accompanied by several physical and cognitive symptoms. So you'll have a sudden fear of what something is worse is going to happen to you, and it would have both psychiatric symptoms as well as physical symptoms. So these physical symptoms are the ones which might patient present to with emergency, and you might get confused whether this is a psychiatric illness or a physical illness. Wherein a panic disorder is characterized by recurrent unexpected panic attack that are not restricted to any particular situation or set of circumstances. So why is it relevant in emergency setting? Very common presentation in emergency room, high level of patient distress and anxiety, need for rapid diagnosis and management. So occasional anxiety is a part of our life, but these things, if they are reoccurring, and overwhelming fear may be a sign of panic disorder. So you should know the sign and symptom. When we talk about epidemiology, panic attacks are very common globally and in India, maybe due to underreporting or lack of awareness, or because of many cultural belief, the reporting might be underreported in India, and the estimated true prevalence could not be very much accurate. But still, lifetime prevalence of panic attack globally is approximately 3 to 5%. And India also, certain studies says it is around 2 to 2.5%. more common in female and especially in younger age group between 20 to 40 years. So what is pathophysiology? Again, we'll remember like a usual biopsychosocial model. Neurobiologically, if we say there is dysregulation of brain fear network, amygdala and hypothalamus, imbalance of neurotransmitters like serotonin, norepinephrine and GABA have been shown to be associated with panic attack. Physiologically talking, sympathetic nervous system hyperactivity which give rise to fight or flight response, and psychological factors like cognitive distortion, fear of losing control, catastrophic thinking, poor coping skills are associated with panic attack. Just an example of how cortisol levels are raised and how the different brain areas are affected during the panic attack. So are there any sign and symptoms of panic attack? Yes, there are. Moving on from cardiac sign and symptom, you might see patient might present with palpitation, increasing or pounding heart or accelerated heart rate. Respiratory system patient might present to you with shortness of breath or sensation of being smothered. They might present with rapid shallow breathing as well. You might get confused whether this is any respiratory distress or whether it is a panic attack. Neurological sign and symptom like dizziness, lightheadedness, tingling sensation, sensation of derealization, GI symptom, nausea, abdominal discomfort, chest pain or tightness, and intense fear or sense of doom that something bad is going to happen. Patient might shake, sweat, or have chills. So just a pictorial description of what are the sign and symptoms of panic disorder. Certain time panic attacks might occur when patient is sleeping. You might get to hear that मैं रात में सो रहा था अचानक से मेरे दिल की धड़कन बहुत तेज बढ़ी और मैं अचानक से उठा और मैं पसीना पसीना हो गया मुझे समझ में नहीं आया क्या हुआ. So this might be a sign of nocturnal panic attack. So what are the differential diagnosis wherein you can get confused whether it is panic attack or whether it is any other medical illness like myocardial infarction? Patient might present with chest pain radiating to arms and back. Pulmonary embolism, signs of respiratory distress, lower, decreasing saturation level can be seen. In asthma exacerbation, thyroid disorder, especially hyperthyroidism, seizure disorder and hypoglycemia. And in psychiatric differential diagnosis, you might see generalized anxiety disorder, social anxiety disorder, certain phobias, PTSD, and substance intoxication or withdrawal are quite similar to that of panic attack. So how to assess other than physical symptoms? Whenever the patient is coming to triage, rapidly evaluate and rule out if there is any other life-threatening condition is there or not. Assess the level of consciousness, monitor the vitals, heart rate, blood pressure, oxygen saturation. I think this thing you practice in emergency as well. Once the patient is medically stable, then you start taking history. So what is the onset, duration and course of symptom? Any recent stresses or traumatic event? Any substance use? Psychiatric and medical history of is there or not, any history of panic disorder or anxiety disorder, any depression, history of previous similar episode, whether wherein you have to rush to the emergency or even at home any altercation has occurred or any unfavorable situation has occurred and you have shown the similar symptoms before. History of medication, benzodiazepine, antidepressants or beta blockers. Family history of cardiac illnesses should also be ruled out. You all are aware that nowadays, especially the young people are also presenting with, especially male, are presenting with myocardial infarction. So you have to rule out if there is an underlying any physical symptomatology is there or not. So when you examine the patient, when you see in journal appearance, patient may appear anxious, restless, or may hyperventilate. He might be sweating, trembling, rapid shallow breathing may be observed. You should also look for the signs of agitation or pacing. Vital sign में heart rate, BP, respiratory rate and oxygen saturation should be monitored. When you're talking about cardiovascular examination, look for irregular pulses, tachycardia, any abnormal sound, heart sound is there or not to rule out if any other associated pathology is there or not. Similarly, in respiratory system symptom, though there might be rapid shallow breathing, patient might be hyperventilating, but also look for any additional breath sounds are there, like wheezing is there or rail is there or not. Again, in abdominal discomfort, patient might complain of mild tenderness or abdominal pain, but you should also rule out any other associated abdominal pathology like ascites अगर तो नहीं है. Similarly, for neurological examination, watch for alertness, orientation, cognitive function, tremor, weakness, any other neurological sign. When you talk about mental health assessment, which is the core of psychiatric evaluation, general appearance and behavior we have already seen. Patient might appear anxious to you. Patient might report intense fear or sense of impending doom. ऐसा लग रहा है कि प्रलय आने वाली है, ऐसा लग रहा है कुछ बहुत गलत हो जाएगा. They might say कि I am losing control or I am going crazy. Ensure there are no other psychotic symptoms like delusion or hallucination. Also ask if there are any thoughts of self-harm or harm to others or there is any history of the same. In blood investigation, apart from journal blood picture, rule out hypoglycemia, thyroid function test, electrolyte imbalance, if possible cardiac enzyme, ECG, chest X-ray and CT chest to rule out any associated chest pathologies there, and neuroimaging. So how do you manage the patient once you have diagnosed कि हाँ ये panic attack ही है? Reassure the patient. Stay calm and offer emotional support to the patient. If possible, move patient to a calmer environment where there are less triggers or environmental triggers are present. Explain to them very calmly that their symptoms are due to panic attack and it is not a life-threatening condition and we can manage it. If required, administer benzodiazepine. Clonazepam and lorazepam are said to have quite a beneficial role in this case, and you can give them parenterally as well as orally, whatever is feasible at that time. Short-acting beta blockers like propranolol can be used to manage palpitation and tremors. In long-term, SSRIs or SNRIs or other antidepressant can be taken into consideration. Non-pharmacological management, which is very important for panic attack. There are certain breathing techniques we'll see in another slides. Encourage slow, deep breathing or instruct the patient to breathe into a paper bag if the patient is hyperventilating. Paper bag breathing is something you all might have seen in television as well कि बहुत ज़्यादा anxious patient है उसको paper bag पकड़ा दो और उससे बोलते हैं कि इसके अंदर inhale exhale करो. So it helps in controlling your respiratory part of anxiety. Then there are certain relaxation techniques, progressive muscle relaxation and guided imagery. Mindfulness and meditation have also been shown to be effective to reduce anxiety. CBT or cognitive behavioral therapy is also is beneficial, reconstructing negative thoughts and behavior. Another important thing is grounding techniques wherein you use your sense organs, we'll see afterwards, and biofeedback and lifestyle modifications such as regular exercise, healthy diet and good sleep habits. So this is how the paper bag ventilation is done. Next is box breathing. This is something you can practice yourself. You can advise to the patient. You can advise to your friends and relatives. So breathe in for 4 seconds and then you have to hold for another 4 seconds. Then you have to breathe out for next 4 seconds and then you have to pause again for another 4 seconds. So box ka rule of 4 yaad rakhna hai. Is it clear? Next is grounding technique. So whenever you feel stressed or you feel anxious or panic attack aa raha hai, so try to be in contact with the surroundings, try to be in present. So use your sense organ. Use 5 things that you can see, 4 things that you can feel, 3 things that you can hear, 2 things that you can smell and 1 thing that you can taste. So using your sense organ will keep a ground reality check that you are currently in present and you are grounded and you are going to be all right. This is a pictorial description of progressive muscle relaxation. You can start from head to toe or toe to head or you can use one particular area of your body. For example, अगर आपने हाथ लिया है तो you can start from making a tight fist and telling them how to release it. Okay, tense, for example, in the face में इसमें लिखा हुआ है सबसे पहला वाला tense face muscle including forehead, cheeks and mouth, upper neck. You can keep it tense for as much as you can. It could vary from 1 second to 10 second to 1 minute, and when you feel like it is getting overwhelmed, so you can quickly release with a exhaling breath. Again, biofeedback therapy, it is a technique which wherein the real time monitoring of your certain peripheral activities of the bodies are seen, like EEG is there, respiratory and heart rate variability is there, EMG is there. So whatever the symptoms are you are facing physically and physiologically can be monitored, and you can keep it keep it as a check. Yes, these things are changing, and this is something which can be taken into consideration. And this sympathetic and parasympathetic abnormalities can be how we can manage it of our own. So to conclude, panic attack can mimic serious medical condition and must be quickly differentiated. Immediate reassurance, calming technique, short-term pharmacological management are effective, and long-term lifestyle changes and how we can apply some breathing techniques and grounding techniques can be beneficial. Ensure follow-up and referral to mental health services for long-term management. This is all for today. Thank you. Good afternoon, and let us begin with the topic suicide and para-suicidal behavior. So we'll be covering it under the following headings. So suicide is derived from the term, Latin term, which can be divided into su and cedium. Su means oneself and cedium means killing. So it is an act of deliberately ending one's life. It is a major public health issue and a very emergency issue for mental health professionals. A suicide attempt is when people harm themselves with the goal of ending their life, but they do not die. Suicide pact is an agreement between two or more individuals to die by suicide together, usually the same method and at the same time. Example, a couple may decide to end their life together by overdosing on any sleeping pill. Copycat suicide, an individual attempts or completes suicide after being influenced by another person's suicide, particularly someone they admire or identify with. A suicide survivor is someone, a family member or a friend of someone who has died by suicide. This is a term which we use for suicide. Para-suicidal behavior, any non-fatal, serious, deliberate self-harm with or without intent of suicide. So here the intent part is important in para-suicidal behavior. The intent is not clear. Like in suicide, it is clear we have to harm ourselves. In para-suicidal behavior, it is not that clear. Para-suicidal behavior is often used as a coping mechanism or cry for help in the face of overwhelming emotional pain or distress. Another term is suicidal ideation. These are the thoughts, ideas, or plans about ending one's life. It can be active or passive. Active means people might plan properly, but there is no action taken. And in passive suicidal ideation, patient might say, "Ki, I wish I do not have to wake up in the morning." These kind of sentences. So suicide is a leading cause of death worldwide among the age group of 15 to 29. WHO says that approximately 700,000 people die by suicide each year, and for every suicide there are many more attempts. In India as well, NCRB data of 2021 says that approximately 164,000 recorded suicide were there. Recorded suicide, there are several which would have not been even recorded. 12 per 100,000 in India the data stands. Highest rate is among 18 to 45 age group with notable gender difference. So the committed suicide are more high in male, whereas the attempted might be more higher in female, but the rising tendency towards female suicide is also been seen. In states like Maharashtra, Tamil Nadu, West Bengal and Karnataka, higher rates are there. Agrarian or a farmer suicide and students are at higher risk of committing suicide. So certain theories of suicides are there, which is again biological, psychological and social. Biological theories are like neurotransmitter theory, like particularly serotonin and its metabolite 5-HIAA have found to be comparatively low level in a patient who commits suicide. Again, genetic predisposition in family and twin studies indicates that genetic factors may contribute to suicide risk. Individuals with a family history of suicide or mood disorders are at higher risk of suicidal behavior. Then psychological theory. Sigmund Freud have given internalized aggression the term. He says that there are several conflicts which are there, actually like guilt or some loss, which may manifest as suicidal thoughts. Aaron T. Beck, as we all know, gave the 3 hopelessness, helplessness and worthlessness criteria of suicide. Escape theory is something which says that patient, in order to escape the intolerable psychological pain, failure or self-perceived inadequacy, commit suicide. Again, Thomas Joyner gave 2 key psychological states. एक तो वो term है perceived burdensomeness. The patient believes that that I am a burden over other and death is the ultimate solution which can be which would be beneficial for my loved one if I passed away. Thwarted belongingness, the feeling of isolation and lack of meaningful connection with others. Very important is this social theory. Durkheim's theories have divided suicide into 4 types: egoistical, altruistical, fatalistic, and one more is there. Egoistical theory says that individuals feel disconnected from society or lack of support. People may feel alienated or isolation and may contribute to a sense of meaninglessness. Altruistic is something where people are very much involved in the society and social group. They may sacrifice their life for perceived good of the people. For example, war. Anomic suicide is where societal instability or normlessness, like someone has lost a job, sudden economic collapse is there, so patient commits suicide. Fatalistic society result from excessive social regulation and control. People may feel oppressed or rigid by rigid societal structure or life circumstances, like people in abusive relationship or prisoners. Social learning theory, patient Albert Bandura gave this theory. He said that it can be learned from observation and imitation, especially patients who have particularly within family, social group or media can influence. The term is called contagion or Werther effect. Etiological and risk factor, again biological factor, again we have discussed already. Genetic predisposition, neurotransmitter dysregulation, brain abnormality. Psychological, cognitive distortion, personality disorder, mental health disorder, substance abuse, social environment, employment, poverty, social stigma, social attitudes towards honor, shame, and easy access to the things which can lead to cause suicide. In psychopathological, personality disorders are very much associated with parasuicidal behavior. This is biopsychosocial model of suicide. Are there any warning signs of suicide which say कि patient बात नहीं करता, ऐसा कुछ नहीं है? There are certain things which you should know. Patient talks about wanting to die. There is a feeling of guilt or shame, being a burden to other. He might feel hopeless, helpless. Behavioral changes. He might started acting very rash. He might involved in some sudden substance consumption. He may plan or research the way of dying. Withdrawing from fans, saying goodbye, giving away your possessed thing, making a documented will. These are something which should be taken into consideration. Suicide methods: hanging, drowning, poisoning, firearms, and overdose of medication. Whereas parasuicidal behavior like cutting self, hitting oneself, banging head, overdosing on non-lethal medications, and superficial burning. This is also NCRB data which shows that hanging is still the most common method of committing suicide. If the patient has attempted suicide, determine the method, timing, and circumstances of the attempt. Inquire about suicidal ideation. Inquire about frequency, duration, and intensity of thoughts. Ask whether the patient has a plan. Develop the plan. Determine if the plan is specific, feasible, and time bound. Assess the patient's intent to act on these thoughts. Inquire about any previous suicide attempt or parasuicidal behavior, any psychiatric illness, rule out any drug or substance abuse, any chronic pain or illness is there which can also lead to the suicidal or parasuicidal ideation. Find about any stressor, how is the support system or coping mechanism. In mental status examination, appearance and behavior of the patient, mood, how he is feeling, how do you see patient is appearing to you, whether in his thought content there are hopelessness, helplessness, or any active suicidal ideation or passive suicidal ideation present. How is his insight and judgment towards himself. There are certain scale, like for example, Columbia Suicide Severity Scale, sad person scale. This is the example of sad person scale. So how do you manage the person who is has attempted suicide or has made a parasuicidal attempt? First of all, if the individual has attempted suicide, immediate medical stabilization is the top priority. Monitor airway, breathing, and circulation. Initiate necessary steps such as gastric lavage or intravenous fluid depending upon the substance ingested if the poisoning patient is there. If there is any overdose, see for any antidotes are there. If at all activated charcoal for certain injections are required, it is there. If there is any self injury, life-threatening injuries, deep cuts or self-inflicted would manage proper medical care. Even in parasuicidal behavior, which is not intended to cause death, the physical consequences should be treated immediately. Once the patient is medically stabilized, a comprehensive suicide risk assessment should be conducted. Remember three terms: intent, lethality, and method. The presence of ongoing suicidal ideation is there or not, these things should be kept in mind. In parasuicidal behavior, assess the frequency and motivation behind the harms. There might be certain emotional overwhelming, there might be certain attention seeking behavior or any triggers which can lead to parasuicidal behavior. Create safety plan with the patient like identifying triggers, coping strategies, removal of the mean, ensure that the lethal means firearm, medication, sharp objects are removed, consider hospitalization. Once hospitalized, why are you hospitalization? Why do you hospitalize the patient? If there are any active suicidal ideation with a clear plan or intent, if there is any severe psychiatric condition like psychosis or severe depression, past attempt of suicide is there. Once the patient is hospitalized, please monitor 24/7. Patient should be in a safe suicide-proof environment. Even in the ward itself, there should be no object, including दुपट्टा, दवाइयों का कुछ भी है वो नहीं होना चाहिए जिससे वो अपने आप को harm कर सके. He or she should be even assisted when he is going to the bathroom. Pharmacological management: antidepressant, antipsychotic, mood stabilizer, benzodiazepines. Brain stimulation, ECT is one of the most preferred and most utilized method. अगर patient में suicidal, active suicidal ideation है, ECT is very much preferred. RTMS is another one method. Pharmacotherapies में cognitive behavior therapy is most effective, wherein the cognitive distortion, which will focus on your negative thoughts with healthier and more realistic thoughts. Coping strategies and how to deal with stress will be taught. DBT is said to be more beneficial for personality disorder, wherein the parasuicidal behavior is being found. Mindfulness based therapy, wherein you will be taught how to acknowledge what you are feeling. Menstrual time बच्चों को पता ही नहीं होता when they are getting angry, when they are getting sad, to acknowledge that feeling. Why are these thoughts and emotions coming, and what are these thoughts and emotions? Involvement of the family is critical, and rehabilitation and aftercare so as to prevent the future attempts and for a beneficial afterlife of the patient. Public health initiatives to prevent suicide, like district mental health programs can be there, media campaigns can be there, school and college mental health initiatives are also taken into consideration. Farmer suicide prevention, government schemes such as loan waivers, agricultural counseling, and farm support for financial stability. Reducing access to lethal means already discussed before. What are the challenges? Stigma and mental health is still there despite advancement. Stigma around mental health and suicide remains high, preventing many people to seek help. There are certain traditional belief, family honors, which play a crucial role in seeking help. Lack of resources, shortage of mental health professionals, and lack of awareness is one of the few challenges which we see. Legal issue: Mental Health Care Act provides rights to individuals with mental health issues, including access to mental health service and privacy. Involuntary admission can be taken into consideration when person poses a threat to himself. And Section 309 IPC decriminalize जो कि suicide को criminalized act बोलता था, it has been decriminalized in 2017. These are certain helpline numbers, especially Kiran is a government initiative, government mental health helpline which works 24/7. There are Smartians in Mumbai, Astra, I don't know whether it's in Hyderabad, no, it's in Bangalore, I guess. Roshni and Snehi are another help group which can be consulted. So to conclude, these are preventable behavior which can be suicide and parasuicidal behavior, very much preventable public health issues and required urgent attention, awareness, early identification and intervention by healthcare profession. And it is again requires collaborative approach involving medical professionals, social work, community support and government. And we have to keep a point ki reduction of stigma and increased accessibility of mental health care should be there.
Okay, so welcome again. Now the next topic in Psychiatry Emergency series is the psychiatric aspects of domestic violence, elderly abuse, child abuse, and rape. So these are again the cases that you are going to see, maybe not as commonly as delirium or others, but you need to know how to understand these cases, how to manage these cases. So I'm Dr. Swaleha Mujawar, assistant professor, and I'll be teaching you about these cases. So first, the psychological aspects of abuse. So understanding these scars are very, very important. So abuse can be in various forms, and any form of abuse leaves a deep psychological scar that can significantly impact mental health. So whether it is domestic violence, elderly abuse, child abuse, sexual assault, any of these trauma can lead to a range of mental health challenges which affects the individual across the lifespan. So not necessary that immediately they'll have consequences of the abuse. The abuse can have implications even after years. And this presentation will cover the psychiatric ramifications of abuse, the specific mental health conditions commonly associated with each form of abuse, and some insights into the therapeutic interventions available for recovery. In fact, if you want some reading, extra reading, there is a book called as Body Keeps Score. So that book discusses the mental trauma and how the mental trauma leads to physical symptoms also. So it's a very interesting. It's not a academic book. So I'm not telling you to read this for your exams, but if you're interested and if you want to read, it's a very interesting book. So first coming to domestic violence. So the impact of abuse of domestic violence. So it leads to depression, it leads to anxiety, it can cause PTSD also. PTSD is your post-traumatic stress disorder. So the constant fear and power imbalances in an abusive relationship can have devastating effects on mental well-being and their day-to-day life. And seeking help and support is also very difficult for these kinds of patients. So reaching out for help is a sign of strength. Therapists, support groups, legal resources, any of which can provide help to them, can help them heal from the trauma of abuse and rebuild a new life which is free from violence. So, like I've told you, it can lead to depression. So, domestic violence can lead to persistent sadness, low self-esteem, feelings of worthlessness. Post-traumatic stress disorder has a different presentation. So, exposure to violence can trigger PTSD. This is characterized by intrusive memories, nightmares, and avoidance behavior. Anxiety disorders can also occur secondary to domestic abuse. So this is characterized by intense worry, panic attacks, and a fear of being alone. So all these three things can arise from domestic violence. And depression, again, we've seen that yes, it leads to sadness, PTSD, anxiety, but substance use disorders can also occur. This is less common, especially in the Indian context. If the female has domestic abuse, it is very unlikely that she'll go into alcoholism or any addictions. So, less common, but yes, domestic violence can cause victims to turn to drugs or alcohol to cope with their trauma, and this can lead to addiction, it can lead to further complications. So always remember that yes, you're asking the patient about depression, PTSD, anxiety, but also ask if there is some substance abuse problem also. And what can we do as doctors? How can we help them in healing and recovery? So one important and most important thing is safety planning. So safety planning is vital for escaping domestic violence. So it involves creating a personalized plan to ensure safety during and after leaving an abusive relationship. So safety of the patient is very important. This plan should include practical strategies for escaping danger, securing resources and protecting oneself from further harm. So this is something which happens very commonly. So safety planning is important. Escape routes. So identifying escape routes and safe havens is a key. So having a plan for quickly and safely leaving, including designated exits, transportation is crucial. Legal protection is also very important. So seeking legal protection, like they might have a restraining order, so this will help create a barrier against the abuse. This can involve working with legal professionals to file for a legal protection, ensure that the abuser is held accountable, and safeguarding the victim's well-being. So these are the first things that you should do if you know that the patient has domestic violence. Apart from safety planning, from our side, we have something called as cognitive behavior therapy. So this therapy challenges distorted thoughts and beliefs influenced by abuse. Because of constant abuse, the way of their thinking or the way of looking at life actually changes. So CBT makes their thinking normal or makes their thinking actually different from what was there during the abusive period. There are trauma focused therapies also. So this therapy specifically focuses on trauma and how to develop coping strategies. Support groups are also present. So providing peer support and a sense of community actually helps the patient feels very better. If all these things are not working, we have medications also. So medications for anxiety, depression, insomnia. This is like the last step. If the patient needs it very necessarily, then only we give it. Now coming to elderly abuse. So elderly abuse actually is a hidden epidemic. We don't know the actual numbers, but it occurs very commonly. So elderly abuse can occur in various forms. So one is a physical abuse. So physical abuse involves use of force against an elder, causing physical injury to them, causing pain to them. It can include hitting them, slapping them, restraining them. So this is under physical abuse. Emotional abuse can also occur. So emotional abuse is a form of psychological treatment that aims to control them, manipulate them. So giving threats to them, intimidating them, verbal insults, all these come under psychological abuse or emotional abuse. There can be financial abuse also. So financial exploitation involves misusing or stealing their money, assets or properties. It can include forging signatures or coercing them, यानी उनको जबरदस्ती threaten करके या जबरदस्ती करके property lena, money lena. Sexual abuse can also occur. So it can have it can manifest in the form of non-consensual sexual contact with an older adult. It can range anything from unwanted touching to actual forced sexual acts. Neglect is also a form of abuse. So neglect occurs when the elder's basic needs are not met, like food or their housing or safety needs, leading to their harm and suffering. So failing to provide adequate water, food, shelter, medication, personal hygiene, this is also elderly abuse. Then exploitation. Exploitation means taking advantage of the older abuse vulnerability for personal gains or forcing them into some illegal activities on their behalf. So this is elderly abuse. What are the psychiatric ramifications? Very similar to domestic abuse. it can lead to depression. So elderly abuse can lead to depression marked by feelings of hopelessness and worthlessness. The abuse may trigger a sense of isolation and social withdrawal, making it difficult to enjoy their day-to-day life. PTSD can also occur. So trauma of abuse can lead to PTSD, which can cause nightmares, flashbacks, avoidance behavior again. This can significantly impact their quality of life, making it difficult to cope and deal with their everyday stressors. So anxiety can also occur. So constant fear of further abuse. Victims may experience persistent worry, generalized anxiety disorder, panic attacks, and again their sense of well-being is impacted due to this. Now coming to child abuse. So one is what is trauma informed care. So if a child abuse patient comes to you, identifying them and treating them is a challenging thing. So trauma informed care is central to helping child survivors. This approach emphasizes understanding and addressing the child's trauma history while avoiding re-traumatization. So, child abuse patients are the most delicate and the most tricky patients to deal with. Sometimes play therapy helps in them. So play therapy provides a safe space for children to express their emotions and experiences through play. Because as adults, we are able to express whatever things have gone wrong or whatever abuse is there, but children are not able to tell. So through play, we can actually extract that information. And family therapy is very important. It addresses the dysfunctional family dynamics and aims to improve relationships, also creates a supportive environment for healing and growth of the child. So child abuse, we don't want to accept it, but it is there very, very commonly. 1 in 7 children in the United States have some form of childhood abuse or neglect before the age of 18 years, and this is according to their National Child Abuse Helpline. So this is very, very high if we look at it. So the epidemiological point of view, a lot of cases are occurring. 80% of these cases will have long-term effects. So up to 80% of child abuse survivors suffer from at least one mental health issue as adults. So this mental health issue can again be depression, anxiety, PTSD, substance abuse, and around 1500 deaths can occur from abuse and neglect. So this is a very serious condition. We need to treat this very, very effectively. So impact of abuse on child's mental health. So child abuse is a devastating reality, and it leaves permanent scar, emotional and psychological. So it encompasses a range of harmful behavior like physical, emotional, sexual abuse, neglect. And now we are going to see what mental health impacts are there and what interventions can occur. So again, PTSD can occur. PTSD, again, the symptoms are same: flashback, nightmares, hyperarousal will state, emotional numbness, and these symptoms can significantly impair with their day-to-day life, making it challenging to cope with everyday situations, maintain healthy relationships. Specifically seen in child abuse cases are attachment disorders. So abuse can disrupt the development of a secure attachment bond, leading to difficulties in forming healthy relationships with caregivers and peers. So we have something called as a reactive attachment disorder. So this is what is diagnosed in these patients, especially if they have marked difficulty trusting and connecting with others. So attachment disorders are specifically seen in these patients. and sometimes they can have developmental delays also. So abuse can harm a child's development, impacting the ability to learn, control their feelings, build healthy relationships. So they can have delay in language skills, delay in social skills. Their schoolwork is also affected. So early intervention and support is very, very important. Sometimes their emotional regulation is impaired. So abused children often struggle to manage their emotions, experiencing anger, anxiety, or withdrawal. They may find it difficult to understand and respond to others' feeling, making social situations challenging. Also, self-esteem and identity. So abuse can damage because see, self-esteem is made during the childhood, mostly during the teenage part. And if abuse is occurring during that time, their self-esteem and identity is also impaired. They may internalize the negative beliefs about themselves, so they might not have confidence, they might have difficulty experiencing happiness. And of course, depression and anxiety are, as is seen with elderly and domestic abuse, even seen in abused children. So they will have feelings of sadness, worthlessness, fear, worry. These emotions can manifest as depression and anxiety, making it difficult again for engaging in day-to-day activities, experiencing joy, making healthy relationships. These children can have behavioral problems also. So sometimes the children might get aggressive, they might have oppositional defiance, withdrawal, and social isolation. So these behaviors are actually a coping mechanism for them. It helps them decrease the emotional pain and trauma, but we need to change these coping mechanisms to much healthier ones. They can have self harm and suicide also. So the overwhelming emotional pain from abuse can lead to some children engaging in self harm or suicidal thoughts and actions. It is crucial to recognize these signs, provide support, and also to prevent tragical outcomes. So this was the trauma-informed care in abused children that we've seen. So play therapy, family therapy is very, very important. Trauma-focused therapy, again, there is something called as cognitive processing therapy, CPT, and very specific to treatment of PTSD and specific to abuse patients is something called as EMDR. This is eye movement desensitization and reprocessing. So what is done is patient is asked to look at object, and they are made to move their eyes. And when their eyes are being moved, we ask them to tell about their trauma and to process their trauma. So this is found to be very, very effective for addressing trauma related symptoms like nightmares, flashbacks, avoidance behaviors. These therapies help children process traumatic experience and develop the coping skills. Then we have family therapy. So for children in foster care or adoption, family therapy can help build secure attachment with new caregivers. This type of therapy focuses on developing communication skills, establishing boundaries, and creating a sense of belonging. Supportive education is also very, very important because they are spending most of their time in schools. So educating teachers is very, very important. Educating caregivers, community members about the trauma informed care helps create a supportive environment for abused children. This ensures that they receive understanding and appropriate support in various settings. So this is what you can do in helping them heal as a treatment strategy. Now coming to the sexual abuse victims, or what can you do in cases of sexual abuse. So these patients will also have PTSD, depression, anxiety, as was seen with other abuse victims. So similar symptoms will be seen. But apart from that, they will also have, it will also impact their sexuality and identity. So they might have sexual dysfunction. So sexual assault can profoundly impact a survivor's ability to experience intimacy and pleasure. So they will have fear, anxiety, emotional numbness during the sexual encounters. These difficulties can stem directly from the trauma or some negative beliefs that have developed about sexuality as a result of the assault. So, extra problem which is seen is sexual dysfunction. Sometimes patient might present with dissociation also. So sexual assault can leave the survivors feeling disconnected from their bodies and emotions, and this response is called as dissociation. So dissociation can manifest in the form of detachment from reality, feeling numb to emotions, even experiencing a sense of observing oneself from the outside of their body. This detachment, while initially a coping mechanism, can make it difficult to process trauma and navigate the relationships. So again, this abnormal coping has to be replaced with a proper normal coping. Then self-harm and suicidal ideations are also very, very common in these patients. They can engage in self-harm as a just as a way to manage their overwhelming feelings. uh, but this is not a solution. This is again a very abnormal coping mechanisms. These suicidal thoughts can arise from the trauma, stemming from feelings of worthlessness, hopelessness. It is crucial to remember, you have to remind these patients that help is available. So reach out to a mental health professional, reach out to a support network. There are lots of help available, suicide helplines are available even in India. So teaching them that somebody is there to help them actually helps a lot. What are the other things that you can do? One is therapy. So therapy can help survivors process their trauma, manage symptoms like anxiety, depression, develop positive coping strategies. And trauma focused therapies like CPT, EMDR, these are also helpful. Then not just therapy, in the community a lot of support groups are there. So they provide safe spaces for survivors to connect with others. So how others dealt with the experiences, they share stories and they receive some validation from fellow survivors. That can be very, very empowering for them. Empowerment therapy is also there. So it helps survival rebuild a sense of control over their lives. This type of therapy focuses on usually self-care, setting boundaries, reclaiming their sense of self-worth. But yes, if nothing is helping, we have medications also. So medications like selective serotonin reuptake inhibitors, they can help manage symptoms, improve our overall self care, self being, and self worth. Working with mental health professionals is crucial to determine the appropriate treatment plan. So usually the psychiatrist or the mental health professional determines that what type of therapy should be given to the patient. So with this, we end this lecture. Again, if you have any doubts, if you have any questions, questions are welcome.
Good afternoon. So let us begin today's topic, which is violent and homicidal patient in psychiatric emergency. So this is something which you are very much frequently aware of. You see these patients in your day-to-day life, not just in emergency. You might see in your private practice if you are going to do it in future. We'll be covering it under the following headings. So what do you mean by violence? Violence is defined as the intentional use of physical force or any other power which is threatened or it's applied actually. It could be against your own self or another person or against a group or community that either result in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment or deprivation. It's not that ki violence will always cause a harm, but it has very likelihood of causing a harm. Violent behavior, again it refers to any action where physical force is used to harm or threaten another person. It can range from minor assault, thappad maar diya, to aggressive physical form, or including murder or severe physical harm. Then we have homicidal behavior. What do you mean by homicidal behavior? Any thoughts, action, or the intent to kill another person. It can include both premeditated or impulsive action that can result in another person's death. Homicidal ideation is something wherein you have the thoughts regarding harming someone, which can range from vague ideas of revenge to detailed and fully formulated plan without the act itself. So they are just ideation. Action part will be lacking, but the ideas will be present. So types of violent behavior, what all patients you can see verbally aggressive patient. It includes language to harm or intimidate another person. It may involve shouting, threatening, insulting, or using abusive language, which is aimed at provoking fear or distress among the individual. Physical aggression, use of physical power to cause harm to another person, for example, hitting, slapping, kicking, punching, biting, or throwing objects at someone. Next is property destruction. This is also something you are quite familiar with. Violent behavior involves intentionally damaging or destroying personal or public property as a form of aggression, which is often associated with emotional dysregulation or frustration. You might break the windows, smashing furniture, or vandalizing the property. Again, the violent behavior could be divided into impulsive violence or premeditated violence. What is impulsive violence? Impulse itself means action without thoughts. So the thought part will be lacking here. Acts of aggression that occur spontaneously, often as a reaction to a stressful or a provoking situation. It is characterized by lack of planning and emotional dysregulation. For example, you are having a conversation and heated argument can turn into verbally abusive or a physically abusive act without even thinking you might get physically abusive. Premeditated is something where you have a clear plan of assaulting or carrying out a homicide towards someone else. So in emergency department, globally the studies say, depending upon what kind of facility you are in, 10 to 50% patient can present, psychiatric patient can present with violent behavior at some point of life, point of time in their care. Similarly, in India as well, there are certain studies conducted which says about 15 to 25% of psychiatric patient in emergency setting can exhibit violent behavior. Verbal aggression followed by physical aggression is common. What are the etiology and risk factor? Again, biopsychosocial model of disease is quite important here as well. So the interplay between biological vulnerability, psychological and environmental stress, medical condition is important in understanding the etiology. So genetic predisposition is a gene called MAOA gene. There is a mutation of polymorphism in that. This gene is also known as warrior gene, which is linked to increased aggression and impulsivity. Again, younger age group, especially 18 to 35 age group, male gender is more prone for having violent and aggressive behavior in comparison to female. But it doesn't rule out that female won't be violent or aggressive. Again, neurotransmitter dysregulation, dopamine and serotonin level dysfunction can lead to violent and aggressive behavior. Medical and organic causes should also be taken into consideration. Patient with traumatic brain injury, electrolyte imbalance, post-seizure confusion, and in delirium patient can be violent and aggressive. Brain structural and function abnormality like amygdala hyperactivity, or if there is frontal lobe dysfunction, so these situation can also lead to aggressive behavior in the patient. Higher level of testosterone have been linked to increased aggression in both men and women. Psychologically, mental health disorder, as I've already discussed with you, personality disorder, especially antisocial personality disorder, borderline emotionally unstable personality disorder per se has high likelihood of having aggressive and violent behavior. Again, in substance intoxication, alcohol intoxication and stimulant like methylphenidate, etc. are associated with aggressive behavior. There's a term called impulse control disorder. So it is a disorder which is characterized by sudden, uncontrollable outburst of aggression. That is, this, remember this term, disproportionate to the triggering event. So the event might be very small, but the reaction of the person would be way out in comparison to the impulse or the event which is there. So these patients are also more prone for violent outbursts and property destruction. Environmental and social factors, childhood abuse, how many a time patients or the children who have been, physically or sexually or verbally abused in their home, they normalize the violent behavior. For them, it is a normal way of responding. Experiencing physical, sexual, emotional abuse during childhood is a significant risk factor for the violent behavior in adulthood. Children exposed to violence may normalize aggressive response to conflict. Individuals living in poverty or facing chronic unemployment experience heightened stress, frustration, and social marginalization, which increases the risk of violent behavior. Again, socially isolated people are said to have more violent tendencies. And easy access to firearms is one of the cause which is seen not in India but in European or Western countries. You can see that easy accessibility to firearm increases the likelihood of homicidal tendencies. Especially in United States, you might have seen there are several school में जहाँ पे बच्चे firearm लेके चले जाते हैं, and there have been many incidences which has resulted in several amount of casualty. So this is just to say that how is the patient going to present to you and how are you going to assess. So this is something in emergency you should be able to recognize. Behavioral sign पहले तो देख के patient को, he might feel agitated and restless, he might pace around, there might be fidgeting, he might be clenching his fist, walking around, might start with verbal aggression, he might get aroused by even a minute of the stimulant. कोई थोड़ी सी तेज आवाज हुई उससे भी उसको गुस्सा आ गया, किसी ने उसको पानी के लिए नहीं पूछा उससे भी गुस्सा आ गया. So threatening speech, abusive language or loud outbursts. Then it will start to physical aggression, unprovoked act of violence. Like it might not directly start with being physically abusive towards the healthcare worker, but he might start punching himself, he might start throwing object, then going towards physically attacking healthcare staff or nearby. Patient might engage in self-directed violence such as cutting himself, head banging, punching the wall, etc. Then psychological symptom, this is something we can rule out in history part as well. Key patient might have some delusion, hallucination, impaired judgment, some anxiety or fear associated. So autonomic signs of hyperactivity can also be noted in these patients, like sweating, tachycardia, pupils are dilated, breathing is rapid and shallow, muscle tension, ready to fight posture are common, indicating that patient is physically preparing for a violent act. Signs of intoxication or withdrawal should also be taken into consideration. Okay, history part and examination part is quite tricky in aggressive patient because you might not get that much of time, but still keep in mind that you might know that there is any substance abuse ka history or not, any past history of any violent attack or any especially recent episode where in public or at home he has got aggressive. Legal history, prior history of arrest or any restraining order is there, and rule out psychiatric condition as well. Any acute stressor, and how is the family dynamic at home. Physical examination, as I told you, is quite tricky. It should be very quick, focused and strategic, aiming to gather essential clinical information like just checking of the vital signs of the patient. Brief neurological examination to rule out any traumatic brain injury, any intoxication or delirium status is there. Physical signs of substance abuse, and always look for injuries if patient has sustained any injuries or self-harm itself. MSc mein most of the thing you can make out from the behavior, but the patient is saying whether he is agitated, he is tense, he is pacing around the ward, his mood, how is his mood, how is his affect. And in thought process, when you talk to patient, if you get the time to talk to patient, you might see the presence of paranoid ideation or delusion or persecution, and poor impulse and judgment might be seen in the patient. These are the scales. Yes, there were certain scales which are there, which you just remember the name. For psychiatry people, HCR 20 is historical, clinical and risk management scale. You rate the patient based on this criteria, and higher the scale, higher is the chance that patient has tendencies of getting violent or is actually may be violent in future as well. Then again, this is Brosset violence checklist. In this, according to the time and day, you can write down and mark it कि patient has been confused, irritable, verbally aggressive or not. And one more thing to be noted is इसमें you also have whatever the what we call what action you have taken to calm down the patient, whether any action was required, whether verbal de-escalation has helped, or whether you have to give him some medication or something like that. Okay, very important ki how do you manage, especially in emergency situation. Ensure the safety first of all. Staff की अपनी और patient तीनों की safety आपको ensure करनी है. Try to de-escalate the situation and the patient and address the underlying psychiatric or medical cause. First of all, immediate safety and environmental control. Risk assessment, as we have seen, we will see by seeing the behavior of the patient or certain checklist, you can find out whether how much of the risk patient is having to act violently. Next is environmental modification. First of all, you should have support staff with yourself. 2 to 4 people should be there who should be trained enough to ensure your safety and patient safety as well. Safe physical environment. Ideally, the setting should be quiet with minimum stimulation. A designated calming room or seclusion area with soft furnishing and no sharp edges may be necessary. Remove potential weapon if at all, maybe a knife or a scissor that you can see in your emergency ward. Maybe patient might use a pen to harm you. So if possible, remove all these things from the likelihood, even the furniture or the sharp objects. Starting with verbal de-escalation. This is the first mode and the primary intervention to calm a patient. So you will approach the patient very calmly, use a soft, non-threatening language and maintain eye contact with the patient. Avoid standing just over the head of the patient. Okay, sudden movement भी avoid करना है. In case you suspecting patient is psychotic, avoid gesturing. जो आप हाथ हिला के बात करते हो वो भी avoid करना है. Be empathetic and you can use that sentences like, I can see you are very upset right now. Let's talk about what is bothering you. Again, another thing is offering choices. You might want to make feel the patient that he is in charge. Like, would you like to sit down? Is it okay if I take your vitals? Would you mind telling me? Are you comfortable over here or shall we move over there? So that the patient is thinking that, हाँ कि मैं in charge हूँ. I am having other choices as well. De-escalation technique, active listening. Why the patient is aggressive? Sometimes just listening can diffuse the anger. Next is distraction and diversion. Suggest an activity that can shift the patient's focus of distress, like offering a glass of water, suggesting a walk. Many times you might have seen कि लोगों को stress balls देते हैं ना punch करने के लिए, just so that his anxiety is being weaned down. Limit setting is something you should know. You should not be punitive or aggressive in your speech when you say that. For example, you can tell patient it is okay to be angry, but it is not okay to harm anyone. So let us find out, work on finding a solution together where we can help you out finding why you are angry, and we should not, any other person should also not be harmed. Next is your pharmacological or chemical restraint. So chemical restraint, please remember, it is not used to treat the illness, but for intentionally inhibiting a particular behavior or movement which is causing the havoc currently. So both oral and IV or parenteral IV or IM medications can be given. Benzodiazepine, especially lorazepam, which you might have seen in emergency as well, and diazepam can also be given. Both IV IM doses can be given. Lorazepam 1 to 2 milligram is a good tranquilizer, so is the diazepam. Antipsychotics में haloperidol and olanzapine. Haloperidol, I think which is most commonly is given in emergency setting. Olanzapine injectable, and there are other first or second generation antipsychotics which I think it is currently not available in hospital pharmacy, but can also be used. Combination therapy of haloperidol, promethazine, and lorazepam is a very rapidly acting tranquilizer. It can also be repeated if the patient is not sedated. Please remember, promethazine should not be given IV. This is something which has happened in emergency setting quite often, but remember that, okay? Give them IM. Monitor for side effects, watch for sedation and respiratory depression, because you are giving benzodiazepine and other antipsychotic which might calm down the patient but have the chances for causing respiratory depression. So ABC of the patient should be taken into consideration. Then dystonic reaction, first generation antipsychotics like haloperidol can cause acute dystonia. So promethazine is something which can use to taper down the current situation. So this is how the patient should be restrained. It could be 2-point or it could be 4-point. In 4-point restraint, one arm is upward, one arm is downward, and two legs are tied. And in 2-point restraint, one arm and one leg will be tied. When do you restrain patient? If he is causing imminent threat, he might be cause harm to self or might be harmful for others. And if any form of de-escalation, whether it is verbal or chemical restraint, have failed. Okay, procedure. Restraint should be applied by a trained team under the direction of of a lead physician. Each member should have a designated role कि एक आदमी हाथ बांध रहा है, एक पैर बांध रहा है, दो आदमी पैरों को बांधने में लगे हुए हैं, तो ये सब चीजें आपको you should be pre-decided. Restraint can be physical or mechanical depending on the facility, and it can be 2 or 4-point. Remember, restraint जब use करते हो तो it should not be very tight. You have to keep on check on vitals of the patient. अगर आप फिजिकल रेस्ट्रेंट यूज कर रहे हो तो मेक पॉसिबल कि उसके बीच में कॉटन लगा दो जिससे कि वो ज्यादा प्रेशर ना पेशेंट के हाथ पैर में करे. Again, it should be used for the shortest possible duration. Once applied, monitor vital, consciousness and circulation to prevent complication like positional asphyxia and circulatory issues. In medical evaluation, once the immediate threat is resolved, identification of the cause should be taken into consideration. Identifying cause, conduct a thorough medical workup to rule out any organic cause such as of aggression such as delirium, TBI, seizure, electrolyte imbalance, any intoxication or any psychiatric cause. Long-term management focuses on preventing future episodes of violence by addressing the underlying psychiatric or medical condition. Pharmacotherapy may be antipsychotic, mood stabilizer, anti-epileptic, antidepressant, and psychotherapy and behavioral intervention should be taken. Another thing is legal and ethical consideration while managing the violent patient. Okay. Involuntary admission, Mental Health Care Act 2070 says if a patient is possessing harm to self or himself, he or she can be admitted under the involuntary admission. That means the consent from the nominated representative of the patient should be taken. Our patient who lack the capacity to make informed decision can be taken under involuntary admission. Use of physical and chemical restraint should be applied whenever it is necessary. It should not be like halka sa patient ko gussa aa raha hai aapne baat diya. No. Informed consent from the nominated representative in case when you are restraining the patient, and this consent should be retaken after 24 hours. अगर आपने अभी बांधा तो ऐसा नहीं कि कल भी आपका वो कंसेंट चलेगा, आपको कल नया कंसेंट लेना है. ठीक है. Please आप consent तो ले लेते हो, you don't document when you are restraining the patient. Write down the date, time when you are restraining the patient. When you are opening the restraint वो भी करना है, हर 20 मिनट में vitals भी लिखने हैं और पेशेंट को कैसा रिएक्ट किया, ये सब कुछ आपको कंसेंट का डॉक्यूमेंटेशन में आना चाहिए, रेस्ट्रेंट के डॉक्यूमेंटेशन में आना चाहिए. Including the reason for its use, the type of restraint applied, duration and the patient's response. Reason for its use की failed verbal de-escalation भी लिखना है आपको. Chemical restraint not possible और failed ये भी लिखना है आपको. While the patient is restrained, the physical and mental condition should be continuously monitored. Again the same thing, and please maintain patient's dignity and during the restraint and sedation process. Patients who have made homicidal threats or committed violence act may undergo psychiatric evaluation to determine their mental competency to stand the trial. Clinician must carefully weigh the ethical responsibility of maintaining patients' confidentiality against the duty to protect potential victims. I think in United States there is a law, if a patient is presenting to you who have said कि homicidal threat दिखाए हैं, तो you have to report it to the law enforcement agencies. In India, although there is no law, but big moral act के उसमें आप कर सकते हो inform अगर आप चाहो तो. Conclusion, again the same thing. Violence is not uncommon. Complex interaction of biological, psychological and social environment is there. Early identification of risk factor and past history of violence is crucial for preventing the escalation. Management is psychiatric emergency setting requires comprehensive multidisciplinary approach, and you should prioritize safety and effective treatment, legal and ethical responsibility. These are your references. Thank you.
So good morning to all. This is regarding the medical emergency and the Mental Health Care Act 2017, and what are the provision to do in the emergency and what not to do is postulated in Mental Health Care Act, uh, and we will look what is Mental Health Care Act and how a doctor of emergency medicine should take care of the patient of psychiatrically ill patients who are presenting in the medical emergencies. What are the provisions and what are the chapters are there? So for brief of Mental Health Care Act, it was enacted in uh, May 29, 2018, and this is the promulgation of MHCA, and this is because of the UN convention, and the countries of UN convention should fully align with the UN convention. So Mental Health Care Act was introduced uh, under the aegis of UNCRPD, and it focuses on the promotion of rights to community, including dignity, rights to community inclusion, dignity, autonomy, empowerment, and recovery for all the people with mental illness. So the preamble of the Act has two parts: provide for mental health care and services for person with mentally ill, and to protect, promote, fulfill the rights of such person during the delivery of mental health care and services. So we will go through the chapter wise. This has 16 chapters. So chapter 1 is preliminary, which talks about the definitions and titles and all. So two things which has to be noted specifically in the chapter 1 is what is mental health establishment. So which building or institution should be considered as mental health establishment under MHCA. So health establishment includes Ayurveda, yoga and naturopathy, Unani, Siddha, homeopathy establishments by whatever name called, either wholly or partly, meant for the care of person with mental illness. Wherever the person is treated for mental illness, and regardless of the modern science, all the institution, all the establishment of other pathies will also be considered as mental health establishment, which is established, owned, controlled, or maintained by the appropriate government, local authority, trust, whether private or public corporation, cooperative society, organization, or any other entity or person, where person with mental illness are admitted and reside at. Wherever the mentally ill person is admitted under the roof for treatment of medical illness, and the person is residing in the building, those building whichever is run by the government, private, or in the personal capacity, will be considered as mental health establishment. This is applicable for rehabilitation centers or also which are temporarily or otherwise established, including any general hospital, general nursing home established or maintained by the appropriate government authority, and so on, but does not include a family residential place where a person with mental illness resides with his relatives or friends. So this is the idea about the mental health establishment. Now, who is the mental health professional? So mental health professional under MHCA is a psychiatrist as defined in clause 10, a professional registered with the concerned state authority under section 55, a professional having postgraduate degree in Manovigyan Evam Manas Roga, or postgraduate degree in psychiatry, in homeopathy, or a postgraduate degree in Unani, in Molizat, which is known as Nafasiyat, and postgraduate degree Siddha in Sirappu Murutvam. So any pathy has a postgraduate degree in uh, for treating for the purpose of treating of mentally ill patient will be considered as mental health professionals, not only the psychiatrist only. So further, what is the clause 55, which is defined in the uh, line 2 of mental health professionals. So 55 says that registered clinical psychologists, mental health nurses, psychiatric social workers in the state to work as a mental health professional and publish the list so and so on. So psychologists, nurses, social workers who are trained in mental health uh, area of the psychiatry, they will also be considered as mental health professionals. Chapter 2 talks about mental illness and capacity to make mental health care and treatment decision. So this has two parts: determination of mental health, capacity to make mental health care and treatment decisions. Chapter 3 is about advanced directive. So one should know what is advanced directive. Advanced directive, uh, advanced directive is a document which is given by the person who is mentally ill, and this is regarding how the person wishes to be cared for and treated for mental illness in mental health establishments, and wishes not to be cared for and treated for mental illness. So this is an advance directive which is documented by the mentally ill person in a lucid state, and he can specify which thing to be done to him when he is being treated and what to not. The individual or individuals in order of precedence he wants to appoint as nominated representative as provided under section 14. So advance directive is also for appointment of nominated representative who can take care of the treatment of the person when he is not in the capacity to make decisions. For emergency treatment, advance directive is not applicable. The advance directive shall not apply to emergency treatment given under section 103 to a person who made the advance directive. Liability of mental health professionals in relation to advance directive is a medical practitioner or mental health professor shall not be held liable for any unforeseen consequence on following a valid advance directive. For example, a treating doctor is following the advance directive what the person has said in their directive how he should be treated and how is not. For example, ECT is required and the person has written in the advance directive that I should not be given ECT during my treatment phase. So the treating doctor or professional is has to comply with that advance directive and not to give ECT if it is very much indicative in the condition. If any untoward consequence occurs, the treating doctor is not held liable for the treatment which is stipulated in the advance directive. So chapter 4 is regarding the nominated representative, how he is nominated, who can be nominated. There is a long discussion in chapter 4, and the chapter 5 is for right for persons with mental illness. So you can see that the what are the rights are being given to them: right to access to mental health care, right to community living, protection from cruel, inhuman, degrading treatment, equality and non-discrimination, right to information, confidentiality, right restriction or release of information in respect to right to access medical record. This is regarding the confidentiality and privacy of the patient. Right to personal contacts and communication. The person can contact and communicate personally with any of the person who he or she want to communicate during the hospitalization. And right to legal aid. So you can see that all the rights uh, which are being enjoyed by the normal people are also being given to them. It is written in this act. They should be they can also be given these rights. So MHCA is more the right oriented and right oriented of the patients, right? What the rights they can have. previously it was not, and the United Convention has ensured that the rights of person of mentally ill people be preserved under the Act. Chapter 6 talks about the duties of appropriate government, 7 about the Central Mental Health Authority, and 8 is for State Mental Health Authority. Chapter 9 is for finance, accounts and audits. Chapter 10 is regarding the mental health establishments, so how the establishment can be registered, procedure for registration, audit, inspection, uh, what are the procedure to appeal to High Court, and all the maintenance of registers and records. Chapter 11 is for Mental Health Review Board, which has an equivalent power as of magistrate, and above that there is only High Court. One can appeal against the medical board in the High Court only. This is regarding the chapter 12 is regarding the admission, treatment and discharge of the patient, and I have picked up the specific section 94 for the emergency treatment, which you may face in your emergency medical setup. Any medical treatment, including treatment for mental illness, may be provided by any registered medical practitioner to a person with mental illness, either at a health establishment or in community, subject to informed consent of the nominated representative, where the nominated representative is available and where it is immediately. Okay, so if one has being treated in medical emergency setup, so nominated representative is immediately be informed regarding the person is being there in the emergency setup for the treatment, or otherwise if nominated representative is not in not available, and this is a death or irreversible harm to the health of the person, one can act in the emergency department to treatment of the person, or the person inflicting serious harm to himself or to the others. The immediate action can be taken. The person causing serious damage to the property belonging to himself or to the others. This is also emergency condition and be treated promptly. And the condition is believed to flow directly from the person's mental illness, not because of the other causes. The explanation is, for the purpose of this section, emergency treatment includes transportation of the person with mental illness to a nearest mental health establishment for assessment. This is also included in the emergency treatment part. The transportation till the patient transported to the mental health establishment, that period of management will also be considered under the emergency treatment. The second point is, nothing in this section shall allow any medical officer or psychiatrist to give the person with mental illness medical treatment which is not directly related to emergency treatment specified under subsection 1. Okay. Any kind of other treatment cannot be given. Nothing in this section shall allow any medical officer or psychiatrist to use electroconvulsive therapy as a form of treatment. So in the emergency part, electroconvulsive therapy is prohibited and cannot be used if it is indicated to. The emergency treatment referred to in this section shall be limited to 72 hours or till the person with mental illness has been assessed at the mental health establishment. So the time duration for emergency treatment is 72 hours, and within the 72 hours the person should be sent to a mental health establishment for further assessment and for management, and whichever is earlier. But there is a different condition like disaster and the emergency declared by the appropriate government. The period of emergency treatment referred to in this subsection may extend up to 7 days in these two conditions. The chapter 12 is also talks about the restraints and seclusion. So it should also be known to you that what is there for restraint and seclusion. It is applied when it is the only means available to prevent imminent and immediate harm to the person concerned or to the others. It is authorized by the psychiatrist in charge of the person's treatment at the mental health establishment. In these conditions, seclusion or restraint can be applied. Shall not be used for a period longer than it is absolutely necessary to prevent immediate risk or significant harm. So the treating mental health professional is responsible for ensuring that the method, nature of restraint, justification for its imposition and the duration of the restraint are immediately recorded in the person's medical note. The restraint shall not be used in a form of punishment or deterrent to any circumstances. It should not be used for punishment or to deter any other circumstances in the management. The nominated representative of the person with mental illness shall be informed about every instance of the restraint within a period of 24 hours. So NR must be informed. The person should remain under regular ongoing supervision of the medical personnel at the mental health establishment. Report of restraint and seclusion must be sent to the concerned board on the monthly basis. Another noteworthy points are central authority may make regulation for the purpose of carrying out the provision of this section. And the board may order a mental health establishment to desist from applying restraint if the board is of the opinion that mental health establishment is persistently and willfully ignoring the provisions of this section. Be cautious regarding the restraint and seclusions also. Chapter 13 talks about the responsibilities of other agencies like police department, the judicial department, and the other various departments, what are their role and responsibilities. The 14 is regarding restriction to discharge function by the professional not covered by the profession. This means no mental health professional or medical practitioner shall discharge any duty or perform any function not authorized by this act or specify or recommended any medicine or treatment not authorized by the field of his profession. So one mental health professional cannot go beyond his capacity and his training. He cannot take or pursue other uh, modalities of treatment for the disorders and the conditions which are not specified by his profession. Chapter 15 is about offenses and penalties uh, in this act, and chapter 16 is for miscellaneous things. So this is regarding emergency treatment and what is provisions under Mental Health Care Act. So one should be aware regarding the emergency treatment, the seclusion restraint, and the other roles and responsibilities under Mental Health Care Act. So thank you.